So welcome everybody to the South West London CCG governing body meeting. I'm pleased to say that we've found a way of live streaming, so hopefully this is now viewable to the public as well. There's an opportunity for people to put questions into the live stream, and if we've got time at the end, we will take those questions in addition to the written question that we've had in advance. I've had apologies for the meeting from Julius Parker from Surrey and Sussex LMCs, and I think I particularly wanted to welcome Dino Pardinani, who I will come to in my chair's update, but this is Dino's first public governing body meeting as the Sutton Borough Chair, so welcome Dino. I'm going to take us on to declarations of interest. So we've got the register of interest. Could everyone declare that the register is up to date and accurate? And are there any particular conflicts of interest that we need to be aware of for any items on the agenda today? No, and I'm taking silence as confirmation that the register is accurate. Good. Okay, let's go straight to the minutes of the last meeting, which was the 2nd of September. So I'm going to go through them for accuracy to start with. So starting with page 1, page 2 of the minutes, page 3, page 4, page 5, page 6. So I'll confirm that those minutes are an accurate record of the last meeting, and I'll approve those. And then on to the action log. There were 2 items on the action log, both of which I'm assured are closed and completed, and certainly the board assurance framework is on today's agenda, which was one of the actions, so I'll take those as completed. Any matters arising that I need to be aware of that we need a discussion on now? No? Okay, I will move us straight on then to the chairs and accountable officer reports. So you have had this in advance, but I'm going to just flag up the key issues from my section of the report, and then I'll hand over to Sarah. So the first thing that I alluded to at the beginning of the meeting was a welcome to Dino Pardinani, who was elected as Borough GP lead for Sutton. So he's taken over from Geoffrey Croucher, who'd served in that role for a number of years. Jeff is going back to full-time general practice in Sutton, and Dino, who has been working in the CCG for quite some time, so has considerable experience, is now joining the board. So we're delighted to welcome you, Dino. Since the update was published, we've had progress on the Croydon Borough lead process as well. So Dr. Agnello Fernandez has been successfully re-elected to the Croydon lead role. So congratulations, Agnello. It's great to have you on board for another term with all your experience and wisdom. So delighted that that has gone through as well. The next part of my update was about the NHS is Here For You campaign, and I think it's particularly worth emphasising this at this point in time as we go into a second wave. We're really clear that NHS services continue to be available for people, not just for coronavirus, but for normal care as well. And I think it's particularly worth noting that general practice remains open for business as usual. We're obviously taking all the measures we need to take to make healthcare environments safe for people, so following rigorous infection prevention and control guidelines and standards, and we are planning on continuing as much business as possible. And that brings me on to the next point, which is planned surgery. So we've been doing a huge amount of work in South West London to get surgical levels back up to near to normal, and we've made really good progress in South West London. We're doing very well in the context of London as a whole, and part of that is we've introduced some hubs for surgical services so that we can do certain parts of surgery or certain surgical specialties in a more effective, efficient way in hubs, making sure that we're doing everything we can for infection control. So that's contained in my update. The final thing that isn't in my update, which I wanted to make you aware of, was the report from the independent reconfiguration panel around the work that we've been involved with for quite some time as individual CCGs, and then more recently as the South West London CCG. So the Improving Healthcare Together programme, which is about investing more than £500 million to build a new state-of-the-art emergency care hospital in Sutton, and also to invest in the hospital sites at Epsom and St Helier. The independent reconfiguration panel was asked to look at this on behalf of the Secretary of State for Health and Social Care, Matt Hancock. They reported back in the last week, recommending that the work continues. In fact, the chair of the independent reconfiguration panel said, "Change is essential and requires significant new capital investment to provide appropriate buildings." And I'm pleased to announce that last night the Secretary of State for Health and Social Care accepted those recommendations, so we are pressing ahead. We welcome the additional scrutiny that this process has brought, and what's great about the recommendations and the fact that the Secretary of State has accepted those is that we can continue with the timeline that we'd set out, which means aiming to have the new hospital open in Sutton in 2025. We've already, as you know, agreed a number of further actions to make sure that future hospitals meet the needs of the local population. We're commissioning an independent deprivation review by the King's Fund to look at the future needs of our communities in East Merton and North Sutton. We're reviewing bus routes into Merton and further south into Surrey, beyond Epsom, and we're looking at car parking on all three sites to make sure there's enough for patients, visitors and staff. I don't need to remind you that 85% of services are staying put on the Epsom and St Helier sites, but obviously 6 major services will be brought together in the new specialist emergency care hospital, including A&E, critical care and emergency surgery. And I think it's worth flagging up that the independent review panel noted that in the future this would provide much better services for a context like coronavirus that we currently find ourselves in. So if anything, the coronavirus pandemic has shown us that this is the best model for providing safe care for patients in the future. So we're delighted that this is proceeding. As you know, we're continuing to have regular meetings with the Trust to oversee progress, but the business case itself is being taken forward by Epsom and St Helier NHS Trust, and we'll continue to keep the board updated on progress as we move forward. So that's my update. I'll hand over to Sarah to give the Accountable Officer update, and then I'll open it up to questions.
Thank you, Andrew. So in my written update, you'll see there's 2 items that are already on the agenda. So 111 first and the flu update. So I'm not going to talk about those, and I'm going to ask everyone to hold their questions on those items till we actually do the full items later on the agenda. But I would like to do a verbal update on a couple of things, and in particular the very good news that we've appointed to Chief Nurse and Director of Quality across South West London. So that's for the CCG and for the ICS. And her name is Gloria Rowland. You can look her up online. She has been working over at Barts as Director of Midwifery. And we're really pleased that Gloria will be joining us at the beginning of January. I think she'll be a great asset to us in South West London, and a really energetic and positive person coming into the system, I think. So that's really, really good news. The second thing I just wanted to update you on, which is a verbal update and isn't in my written update, is around COVID vaccinations. So just so that people are aware that we are starting to do work now in South West London to plan for COVID vaccinations going forwards. We have a SRO and leads, and Tonya and Matthew, who are on the call today, are leads for us in South West London. and therefore if you do have any questions on this, I'm sure they'll be happy to answer it. We don't yet know for sure when we are going to get the vaccine, but we do know that there's a possibility that it could be here in December. So on that basis, we are starting to plan for a December rollout. We're looking at things like mass vaccination centres. General practice, we believe, will be doing vaccinations. There will be vaccinations held in some of our providers so that we can make sure that we can supply those in a reasonable way. And we're looking at what is the infrastructure we need across South West London in order to make that a reality for those that can access a mass vaccination centre, but also for those that can't, such as nursing home residents and others. So we're looking at all of the different options, and we are putting a plan in place. We are confident that we will be in the right place for when the vaccine arrives, but obviously there's a lot of work going on at the moment. So I just wanted to make you aware of that, and we will update you at a future date. So I was going to pause there, Andrew.
Thank you very much, Sarah. So are there questions or comments at this stage? Susan, let me bring you in.
Yes, thank you, Andrew. It was about the planned care element of your presentation. Perhaps you could share with us your thoughts and observations on the impact of the second spike of COVID on the plans and whether there's any impact we should be aware of.
Yeah, so that is being factored into the planning. The original plans for recovery of planned care didn't take into account a second wave, because that was the basis on which we were asked to make the plans. But we have assumed that is going to happen all the way through, and have been doing a huge amount of work to make sure we can continue planned care as much as possible during the second wave. Obviously, that will depend on how large the second wave is, but at the moment we're planning on continuing with planned care as we were. Sarah, your hand went up, I think.
Yeah, I was going to say something, but Matthew's actually put his hand up. I wonder if we ask Matthew, because from a hospital perspective, he'll be able to say a bit more on that.
Sure.
Thanks, Sarah. Thanks, Andrew. I'll take my hand down as well. Yeah, we are continuing our work on planned care, Susan. We've created something called Croydon Elective Centre, which is a protected zone within the hospital, so that we can maintain elective services for as long as possible, and certainly that is our intent. And we have operational plans and infection prevention control guidance that supports that approach, and there are different but similar approaches being followed in the other providers in South West London. And indeed, furthermore, South West London is working as a collective. So, for example, in the Croydon Elective Centre, we're treating some of the longer waiting patients from St George's and offering space to Epsom St Helier, because the fact that it's a protected zone means that we've perhaps got a little bit more flexibility, and that therefore allows South West London as a collective to maintain its elective work for longer. And indeed, if you look at the relative positions of London patches, South West London is performing strongly in terms of its recovery back to levels of activity that were seen pre-COVID. And for Croydon, for example, we're now, the latest figures were 120%, which means that we're doing a bit more than we were doing pre-COVID, and obviously long may that continue. Now, obviously, it depends on how severe and widespread the second spike is, so we keep those plans under regular review. I was talking to my lead clinician just last night about that, and one of the things that we are monitoring now is what the DNA rate and cancellation rate is from a patient's perspective. Obviously, there'll be understandable some concern from people about coming into a healthcare facility when the COVID numbers increase again. We've seen DNA rates somewhere close to 10% at points, and part of what we're trying to do is communicate to people that it is safe. We've taken the right protections and precautions, and we want people to keep coming for their services services that they need, and hopefully through this and other mechanisms we can keep that message going, because we want to do that. The second wave of COVID, one of the different things is we don't just want to do COVID, we want to do COVID plus everything else, and that's certainly what we are endeavouring to do, Susan. So hopefully that's a helpful bit of flavour of what's going on.
Thank you very much. Yes.
Thank you, Matthew, really helpful. So Bruno, from the voluntary services perspective, let me open up to you. You've got a question.
Thank you very much. In relation to the COVID mass vaccination, if it does actually commence in December, do you feel that there will have been enough time to absorb any learning from the current flu vaccination campaign and to apply that so that it does, it is effective from the community's perspective?
Thank you, Ben. A really good question. Tonya, I don't know. Sarah. So what I was going to say is, I was going to say Tonya can answer the specifics, but what I would say is we must remember the flu vaccination and this vaccination are very different. So there will be some learning, but it's a different beast. Sorry, Tonya.
Yeah, Tonya, you're leading both vaccination programs, and I know you've got a clinical reference group looking at it as well, and we saw it at our clinical leadership group meeting yesterday. So I know there's a huge amount of work going on, but let me open it up to you to answer properly.
Just to say, as Sarah said, we are using the flu information and insight work as a basis, but it can only be a basis because of the very different characteristics of the vaccine. But it gives us a framework to start on. Absolutely, Bruno. We're using that as our beginnings to grow on.
Thank you. That's helpful.
Thank you both. So Dagmar?
Yeah, hi, good morning. I'm also coming in a bit more on the vaccination, so the COVID vaccination, because first of all, great thanks to Tonya, because she really attends our weekly IMT of Directors of Public Health. The really important message is local authorities want to absolutely help. Yeah, so and if there are any blockages, etc., we've got Paul Martin, who's the lead in terms of outbreak control in South West London, and he made it very, very clear as well. Do come back if there are any problems that you encounter. We want to do this together. One obviously observation that Bruno touched on is very tight, and there are loads and loads of myths and stories out there, because there is a void of communication, and it will be automatically filled and not always correctly. So is there anything that you could share? I've got a number of councillors as well wanting to discuss this and have raise it in council, and I'm very keen, rather than us all inventing our own little thing, basically googling what's out there, in that we have a consistent message so that we bring the community really with us. That is a sort of plead, and I don't know whether Charlotte is on the line. I completely understand the sensitivity and the staging and the timing. It's all tricky, but the more important to align our comms. So that is a plea and a request. Thank you.
Thank you, Dagmar. Really good question as well, and I think we really appreciate the offer as well of support, and it's important we do tackle this as a system. I mean, we had a good discussion about this at the clinical leadership group yesterday, and Charlotte Gorn is a member of that clinical leadership group, so we had a big discussion about the communication side of this. But I'll hand over to Tonya and then perhaps get Charlotte to come in before I think Matthew, you probably want to say something as well. So Tonya.
So I absolutely agree with Dagmar, and it's the one or two of the priorities we keep raising with the region, and they're raising with national, because it's really important we get the information out, but it's important that we get it right. So I think there is something around we might just have to keep pushing to get, particularly on the evidence base that we talked about in the clinical group and with yourself. So we continue to push for that messaging. They know we need it. And we're not the only people that are asking for it. So we will keep asking, and I know that we're trying to, with Charlotte's team, draft something that we can share, even if it's quite short, with people, just to give people a little bit of information. But it is a tricky one at the moment, Dagmar.
Thanks, Tonya. Charlotte, was there anything you wanted to add to that?
Yeah, I suppose talking with our communities will be really important, but also talking with our NHS staff. I think that will probably be the first part of it, because I think lots of our staff kind of use our NHS services as well as work in our NHS services, and we know that they are influencers in local communities. So we'll be talking to staff and talking to staff about how they feel about it, so that informs how we communicate, and then kind of working in our comms and engagement groups at borough level. So, you know, we have multi-agency groups, so Liz and Bruno sit on the groups in their boroughs and talking about how we can really work together as health and care organisations to communicate consistently and with one voice really about the vaccine and how we go about it. I suppose the other thing just to say is our focus publicly currently is around the flu vaccine, because that is happening now. So we're really keen to kind of focus at the moment our communications and our conversations with local communities around the flu vaccine, and then sort of as we move further forward, then sort of start talking about the COVID vaccine.
So let me take comments from Matthew and then Liz on behalf of Healthwatch in relation to this, and then I'll try and move us on to the next item on the agenda.
Thanks, Andrew. I'll be brief. But the communications piece, for all the reasons that have been said, it's right to raise it. It's one of our key priority areas, and the work that I'm doing with Tonya, sort of leading on this across South West London. I flag for benefit for the members of the governing body and also members of the public that in addition to the communications piece, which is crucial, I would flag two other areas. Firstly is workforce, to make sure we have the people available to help give the vaccine when that's available, and then thirdly the logistics of how actually this will work. This isn't just going to be the same as a larger version of the flu vaccination. As Sarah rightly says, it's a different vaccine with different properties and different needs in terms of how that's going to be administered, and as a result the logistics of how this all works, including where sites are and how those sites are supported, is going to be a significant piece of work, and that's what Tonya and I are focusing the attention of the team we've established for this on. So it's workforce, it's logistics, and it's crucially that communications piece. I'd say those were three of the key, not the only ones, but probably the three key bits of work at this moment, if that's helpful for colleagues.
Yeah, thank you, Matthew, really helpful. Liz?
Sorry, screen's in the wrong place. Yes, just to say that we've got the community engagement group meeting this afternoon, which is with comms, and Bruno and I, but also the other health watchers are on that. So it would be really good, and I realise this has suddenly come up the agenda, but it would be really good if we could have some discussion this afternoon about it, because obviously health watchers will be very keen to help as much as we possibly can on getting clear and accurate messages out.
Thank you, Liz. That's really helpful. Good. So really good discussion there. Thank you, everybody, for your input. Let's go on to item 5 on the agenda, which is an update on mental health and learning disability. We're going to hear from Tonya about the overarching approach to mental health and learning disability. You've got in your pack updates from the borough chairs on some of the specifics going on a borough by borough basis. We're taking that as a written update. The chairs are not going to go through for you today. So we're going to hear from Tonya, and then I will open it up to questions.
Thank you, Andrew. Are we projecting the presentation, or are we just talking through it?
I'm hoping we're able to project.
Yep, should be coming up.
Thank you. So just to begin, I'm really pleased to be able to provide an update on the work we are doing across South West London to improve mental health and learning disability and autism services for our population, and also the outcomes for people using them. I mean, it's fair to say that COVID has had a significant impact on people's mental health and for people living with learning disabilities and autisms. And we know that for some people, those impacts will be long lasting. So while services have adjusted really well to meet people's needs through the pandemic, we know that we need to be able to transform our services to meet a new and growing need that we're witnessing at the moment. So if we go to the first slide. So just to give a bit of context, the snapshot is always just to remind people of the provider landscape and some of the population demographics. As you can see, we have a range of providers across South West London providing services across the whole spectrum of mental health from IAPT to very specialist services. And in terms of the demographics, you can see there that we have obviously a varied deprivation and a significant BME population and an increasing prevalence of both common and severe mental illness. Next slide, please. Pre-COVID, the South West London Mental Health Transformation Board, with partners and part of the clinical summit we had last year, set the ambitions for mental health in South West London. And actually, these are still relevant post-COVID, so we are still working on these ambitions. And we have a good history and a good place in South West London around innovation and good practice, and some of this I've listed here. So we have a very low number of out-of-area placements for our inpatients mental health. We have a very mature South London partnership, a very mature provider collaborative for mental health across South London. We are doing well on our IAPT access and recovery targets, and we have, of course, our school trailblazer work, our mental health support teams in schools. So we've got a really good examples of innovation and practice in South West London. Next slide, please. The most significant priority for us at the moment is a community transformation. There is national transformation money, and we're in the middle of putting our plans together to be able to secure that money. It's not an insubstantial amount of money that hopefully we'll be able to secure to transform community services in South West London. The focus of the transformation programme is on adults and for people who need more than IAPT, and that's increasing access to psychological therapy services, but fall below the thresholds for community mental health teams. Very much our community transformation programme is based on place and delivering integration between physical and mental health, and we had a really successful primary care network workshop looking at this area in September, and a follow-up one is due imminently. Next slide. So the long-term plan, well, we had the 5-year forward view for mental health to begin with, and then we had the long-term plan, which identified a number of priorities for mental health, for the transformation of mental health, and this still stands. But we're reviewing our plans in the light of COVID. Next slide, please. So the commitments we made, we restated within our phase 3 planning response, and most of those commitments around trajectories of improvement haven't changed to what we said we were going to do pre-COVID. There are a couple of exceptions, SMI health checks and out-of-area placements. Out-of-area placements, actually, we've improved our position. SMI health checks are slightly below where we wanted to be, so we're really looking at that. Next slide, please. So we've had quite a lot of work done on a COVID recovery plan for mental health and resilience planning, and as you can see from the list here, it's all age, from children and young people's mental health and up to older people's services, and also looks at not just the service offer, but looking at inequalities and population requirements, and also the changing models of delivery. We've done a lot of work with our IAPT providers to make sure that we've got enough capacity, not just for existing demand and for the projected surge. A little bit later on, I'll talk about the crisis care services we've put in place. And we've also had a really good response to the improvements we've put in for children and young people's mental health, the rollout of COOF particularly, which is a digital offer for young people. But the fact that we were able to continue to deliver our mental health support teams in schools, we think helped support we didn't see the projected demand in CAMS referrals as we could have seen, we think, if we hadn't had those services in place. Not to say that CAMS referrals hasn't gone up, but we could have gone up further if we hadn't had that offer. Next slide, please. This slide just shows you the operational changes that we made through COVID to help support mental health services and the people using them through the pandemic. You can see everything there from infection control and standards and how we amended services, staff support and partnership working. I think the thing I would want to just highlight on this slide is the virtual by default, and being really careful that we recognise that for people with mental health and learning disabilities, actually, sometimes it's not easy to use virtual modes of having consultations and access, and we're looking at how we can make sure that the virtual by default works for those population groups. Next slide, please. So how did we respond, and what was the response to surges in demand? As you see, for inpatient utilisation, we managed to manage within the overall bed base over the past 2 years, and we saw that through the COVID period. Bed usage did fall. And that's really good, because that means we don't have to use private providers and we don't need to put people out of area for their treatment. We have had the Lotus Suite in place now for a number of years, and is still highlighted nationally as a good practice, because that delivers a 17% reduction in total informal admissions and a 28% reduction in 0 to 5 day admissions. So this is really a really good pathway for patients. We have seen a 20% increase in bed utilisation modelled as part of the COVID response, so we did that. We did do the modelling to include that increase, but the crisis pathway interventions in place have prevented demand reaching this point. As I said previously, I think one of the really best or good innovations that we did through COVID was the crisis pathway support, which we're continuing through this financial year. And that's around the 24/7 mental health support line, which is diverting activity back to non-emergency services, and the Orchard mental health emergency service, which has been implemented and has been very well received. And recovery cafes are open and continue to be open through the crisis, the first wave of the pandemic, and they remain in place. The next slide, please. Of course, we know that supporting staff and carers with their mental health and emotional well-being is really important, and even more so as we particularly go into winter. And I'm very pleased to say that we've been able to secure £335,000 to develop and deliver mental health well-being hubs across South West London, and that money is available to the end of the year, and we will use some of that money to focus on our more high-risk staff groups, such as our BAME staff. Next slide. So children and young people's mental health. We know that we've done very well in South West London through Andrew's leadership to secure 4 waves of money for improving children and young people's mental health, and that's particularly around the rollout of mental health support teams in our schools, and that work continued through the COVID pandemic, and we have been recruiting to those teams. We've also been able to extend our COOF offer, which, as I said, is an online counselling service for self-referrals to children over the age of 11, and that is absolutely in all our boroughs now. Next slide, please. Of course, patient and public engagement and insight into what we're doing and what works for people is really important. I'm not going to go through all that. You can read that. I think the areas that are most probably the areas that we need to focus on, particularly as we go into winter, is around the access, to make sure that people are aware that services are still available for the population to access, and that we absolutely recognise that there is going to be some impact, probably mostly in anxiety and low mood, worsening over time rather than an SMI group, and actually focusing our support in that. And our Citizens Insight work, we've gathered that from a range of areas, and thank you for everyone who's contributed to that. We had the 6 Health Watch surveys, citizen panel, patient engagement and reference group meetings, the voluntary sector, and the Mental Health Crisis Summit that was held in the summer. So some really good and rich information there that we can build into our plans going forward. Thank you. Next slide. This is some more around the patient and public engagement. Again, you can read it. I won't go through it in detail, but as I said before, there's lots of information there that we will be using and continually to engage with our populations to make sure that our plans reflect what they're saying to us around both in terms of access and the outcomes they want to see from services. Next slide. I've just talked about the summit, the mental health, preventing a mental health crisis summit that was held in July. And there was a similar summit held in South East London as well. And out of that summit, a task force has been set up across 6 focused areas working across South London, and the 6 areas of social isolation, helping people at risk of losing their jobs to cope and how to cope, housing insecurity and environment, supporting disadvantaged communities and groups, supporting families and children and young people, and developing a long-term joined-up approach to prevention. So the work of the teams, the teams have been working on these areas over the summer, and we will report progress back at the next summit, which is on the 10th of November. And so hopefully many of you will have had an invite to that. That's next week. Next slide, please. The risks and challenges, again, I won't go through them line by line, but you can see them there. And I think we need to continue, though we've done quite a lot of work on demand and capacity, we need to continue to do that and refresh that to make sure we have the right levels of capacity in place to be able to meet the demand. And we also need to make sure that we are using all our resources, particularly some of the transformation money that we're lucky to have for mental health, that it's focused in the right areas to deliver the changes that we know that we need to make. Next slide, please. And our future priorities are: we have a weekly mental health and learning disability recovery cell that continues to monitor delivery of the COVID recovery plan, delivery of the agreed mental health transformation programs. I've talked about some of them today, particularly the community transformation program, and absolutely embedding the service user and carer involvement in developing our plans. Continuation of the South London partnership work with SLAM and looking at specialist service provision, and I've talked about the summit and the follow-up actions underway. Next slide. So that is mental health. Andrew, did you want me to do learning disabilities as well, or did you want me to take questions on mental health?
I think keep going. Do learning disability and ASD as well, and then we can take questions on the whole range.
Okay, thank you. So learning disabilities and autism, just to give some context, across South West London, we have 18,000 people with a learning disability and or autism. And by 2030, we expect that number to be nearer to 20,000 people. We have 42 people in inpatient facilities with a diagnosis of learning disability and autism, and we've done very well over the last years to get that figure down, and that is in line with the trajectory that we've agreed with NHS England. I think I always want to pull out the significant health inequality people with learning disability and autism face, particularly when you look at the mortality review piece, and which is highlighted that women and men with a learning disability are dying between 23 to 29 years before the general population. That clearly is something we've got to focus on and absolutely make sure that we close that gap. Next slide, please. So reducing the reliance on inpatient care, people will recall this is the Winterbourne piece, and this is transforming care programs. And in South West London, we've done very well in being able to meet the recommendation and the requirements under that program. We have very low numbers of children who are inpatients, and we've been commended by NHS England for our low numbers. Through COVID, we've continued to work on people's plans, and we've held virtual CETRs, which are the case education treatment reviews for individuals, and we are ensuring that those are undertaken in the timely manner. We're piloting work with pharmacists, colleagues, to promote better joined-up care, particularly focused on STOMP and STAMP. STOMP is stopping over medication of people with learning disabilities, that's adults, and STAMP is supporting treatment and appropriate medication in paediatrics. So we've got pharmacists working on that as well. The next slide, please. The other area of focus for us in the learning disability and autism workstream is annual health checks. And in last year, we managed, the national target was to achieve 75%. That is supported by DES and QOF quality improvement domains. And we managed to achieve 65% in 1920, which is a really good achievement. But obviously, we want to make the 75%, and we're focused very much on working with primary care and other colleagues to secure that target for this year. Next slide, please. Learning disability and mortality reviews. We continue to do our mortality reviews within the targets given, and we are one of the highest performing CCGs in England for learning disability and mortality reviews. One of the things that we have done through the learning from the targeted flu campaign is that we have some we're using some of our transformation money for learning disabilities on this campaign, is to really focus on people with learning disability to get that uptake of flu vaccination in that population. Next slide, please. And this gives you just a flavour of the other areas of focus for our transformation programme. I've talked a little bit about STOMP and STAMP. There's also some work around key workers, and key workers is a long-term plan commitment, and that states by 2023-24, children, young people with a learning disability, autism, or both will have, and with the most complex needs, will have a key worker, a named key worker. And that initial work will be targeted at children, young people who are at risk of being admitted to hospital. And we've got some opportunity to bid for some pilot money for that, and we're just looking at how we can do that well. We're working with the local authorities also to do some market analysis and development. Learning disabilities clearly we need to work with our local authorities to improve our offers, and we're doing some work with our local authorities. So we have a whole South West London picture which spans health and care, which allows us to commission joint services and contract management of joint funded placements. Next slide, please. So there are some key risks and issues associated with the programme. I'm pleased to say that we are anticipating that we will achieve the targets that we are set nationally around learning disability and autism, but of course we need to have ongoing oversight to ensure that performance remains on track. The new host commission arrangements will mean that we are responsible for ensuring the poor quality in our local providers is identified and addressed quickly. At present, we're not aware of any issues, but that is a new responsibility that CCG has taken on as part of the long-term plan commitments. And there is something around, during the pandemic, our risk assessment work is being undertaken virtually. And whilst this brings many benefits, there is a risk around they're not as effective as face-to-face. So we'll continue to review the situation across the boroughs. I think that's the end of the slide pack, but yes, it is. So thank you very much. Thank you for your time, and I'm happy to take any questions.
Thank you, Tonya. I mean, there's a huge amount in there and clearly loads of work going on, and there's also additional information that people have had from the boroughs as well. I imagine there will be quite a few questions and comments. Why don't I let me take all the questions and comments first, and then maybe, Tonya, you could just make a couple of notes and respond to them as a whole. That might be the most effective way of doing this. So I'm going to go down in no particular order, but I'll start with Les.
Hi, Tony. I was just going to ask about the learning from disability mortality reviews. Where and how are the review outcomes coordinated and actioned so that we can learn from across the boroughs?
Thank you, Les. Pippa?
Thank you. So I've got a couple of questions, and I can also add to the response that Les has just asked about learning disabilities, and the leader reviews. We've had a discussion both at the quality and performance recovery work stream around this and at the directors of quality, and there is a piece of work going on now to coordinate learning disability review learning across South West London. Previously we did it by CCG, and one of the directors of quality is doing that piece of work now, so we will get that and we can look at it at QPOC. My question really to Tonya in a comment was to thank you first of all. It was really, really good to see all the incredible work that's going on, and it was also useful to see the patient and service user involvement that is taking place to influence this work stream. And I just wondered, you've got another workshop coming up, whether in future we could absolutely see that transparently, the kind of you said we did, so that we can see the impact of that service user involvement. So that was my first thing. And the second thing was around the LD and ASD. You mentioned about the new host commissioning arrangements, and I just wondered, and it's not something I've had a conversation with directors of quality about, whether there is something we need to do about strengthening borough oversight of some of those host commissioning arrangements, so they know if they've got providers in their patches and what that looks like. Thank you.
Thank you, Pippa. Susan, on to you.
Yes, thanks, Tonya. Really, really helpful. One comment, really, and one sort of question. One of the themes that's emerging, and I can see you're doing an enormous lot of work around supporting carers. That was a big highlight in your mental health presentation, but obviously a key issue for learning disabilities, and we've picked it up. Carers in the broad sense in terms of relatives and support. I'm just keen that we see them as a key player and partner in helping support the clients in the community, and a lot of our strategies really do put a lot of effort into supporting their mental well-being and also their access to people, particularly at this time of COVID, so that they can be co-supporters in terms of some of our very vulnerable communities. But the main issue really is just for you to share a bit more about how we're handling and responding to those risks, safeguarding risks that we're seeing an increase of as a result of COVID, and a very vulnerable community that we're supporting here. Thank you.
Thank you, Susan. Wow, I mean, a huge range of really pertinent questions. So that was the lay members. I'm going to come now to our borough representatives. So Dino, Borough Chair for Sutton, over to you. You're waiting to come off mute, I think. Dina, I will come back to you whilst we wait for you to unmute. Sorry, you seem to be having a technical challenge there. Let me come to Mark. Mark Creelman, this is your first public governing body meeting, I think, in your locality executive director role for Merton and Wandsworth. So welcome, but let me hear your question as well.
So thank you very much for the welcome. It's less of a question really. It's just at our local kind of overview and scrutiny, there was an amazing amount of work which Tonya's kind of presented, and that's fantastic. It's about how do we communicate that to all our populations, not just about the engagement, but actually the communication about what services are there for them, particularly in COVID, where kind of older people may be experiencing kind of anxiety attacks and not quite sure where to go for support. So it's just about advertising, I think, the great stuff that's going on.
Thank you, Mark. Dino, back to you. You look like you're unmuted now.
Thank you, Andrew, and thank you, Tony, for a really comprehensive update. Couple of points. Assurance, really. Really good to see the ambition that no one experiences a preventable mental health crisis there, and the psychological trauma is on the resilience planning agenda. So my question is about the tracking that you mentioned at the beginning, at the very beginning of the presentation, and it's about the shift, obviously, in mental health presentations, both the clinical mix, but also the acuity as a result of COVID. And also with the post-traumatic stress presentations, which can be delayed as well. I'm just thinking, given also the change in the mode of delivery with digital, how are we effectively positioned to be able to monitor that we have sufficient capacity, skill mix, and our delivery model is effectively fit for purpose going forward, and meets the challenge of reducing health and mental health inequalities. And the second point of assurance I've got is about LD, and it's really just seeking assurance that we have sufficient face-to-face capacity in the system, given obviously there are those patients who may be either digitally excluded or, as you mentioned, those who may be better off being seen face-to-face. Thank you.
Thank you, Dino. So now I'm going to come to kind of representatives of other professional colleagues in the system. So Ian, you did have your hand up, it's gone down, but I'll just take the opportunity to introduce you because this is your first public governing body meeting as well. So Ian Dodds, who's representing the Directors of Children's Services. Did you still have a question or comment, or has it been covered?
It's been covered already, so I don't need to repeat it. Thank you though.
Thanks, Ian. So let me come then to Dagmar, representing our Directors of Public Health.
Hi, thank you very much. And again, just voicing a big thank you to Tonya. Seeing it all together and hearing it, it is really impressive. And absolutely with Mark, we need to get it out there so that people actually know it's there and they can use it. My question is much smaller in a way and a bit parochial, but Tonya, it will not come as a surprise. It is COVID and it is learning disabilities, particularly in our SEND schools. We are desperate to regularly test our healthcare workers and education social care workers in SEND schools. You will be all aware that keeping that going is a heroic achievement. It is messy business, and the idea that you can socially distance, etc., is rather heroic. So regular testing of those staff would really help us. And I just want your voice, together with our voice, wherever we can lobby. The regular staff testing in care homes has really started to show its benefit. We are picking up regularly asymptomatic staff and we isolate, and so far we haven't had any symptomatic residents, touch wood, yet. So there is a proven track record of this. It is not masses of tests. We are talking really a selective approach, but I would really very much welcome putting our heads together, lobby for the fast tests, and if we have any spare capacity in Pillar 1 or 2, to get our heads together, how we can really protect that very needy group. Thank you.
Thank you, Dagmar. And then finally, last but not least, Bruno, representing the voluntary sector.
Yeah, I thought it was an excellent report, Tonya. I did have one question in relation to mental health and another in relation to learning disabilities, however. So from the voluntary sector, we're hearing about organisations that are in extreme difficulty in trying to meet needs on a local level for carers and people with low-level non-SMI mental health issues. And it's quite possible that will be a continuing feature of things. It's possible that some organisations may not recover fully. Do you feel that there's the capacity there to accommodate those kind of shifts in the levels of community support which there are out there at present in relation to mental health? And in relation to learning disabilities, do you feel that the level of integration of CCG planning with local authority planning at borough level is really sufficient? Because in the past, historically, certainly we've seen that there has been sometimes very good levels of it, but the picture isn't quite clear at the moment.
Thank you, Bruno. Wow, I mean, a huge range of questions, and that's pretty broad, Tonya. So I know you've been making notes. I just think they're such good questions. I know we're slightly pressed for time, but I'm happy to stretch this item a bit more. So take your time in answering that, because there was an awful lot in there.
There was, Andrew, and I'm sure I can be quick as well. But and I'm happy to follow up any questions outside the governing body with any members who want to have a further conversation. If I can't give a full response now, because as you say, there's lots there, and I know, and thankfully, lots of people are interested in this, and that's great. So I'm more than happy to come and talk to anyone about this at any time. So that offer's there. I think, Les, we answered your question, so I wasn't going to do Les's unless there was anything else, because I think Pippa answered that one. And then Pippa, you asked absolutely rightly that PPE is embedded in all the work that we do going forward around transformation, that we do. Some of yours said we did. And we're working with Charlotte's team to make sure that we have a really robust comms and engagement piece and that co-production piece with our population. So we'll be able to bring something back in the future. In terms of the host commissions, has been very much done on a South West London basis with borough leads, and everyone is aware of the organisations that are in their geographical boundary. There is a dedicated senior quality lead, I think, has just started with Fergus to make sure that we're on top of this. But we can bring a report back to QPOC for you, Pippa, so that we can share that information. And then we had Susan, supporting carers. Carers are so crucial for working with this population group. I know that this is very borough-based, though, around the carers, and many all boroughs will have a carer strategy, which I'm sure that would emphasise their role and the support that they need to be able to fulfil their role. I think for carers it really is a borough. Because it's so close with your local authority and the approach you do with carers. So whilst there isn't anything operationally that I would do probably at South West London level around supporting carers, it's working with those boroughs to make sure that they're reflecting the needs for mental health and LD in those strategies. And the safeguarding risks that you raised, again, I think Pippa would have a view around, we're getting the safeguarding risks reported through the usual safeguarding route. So I think, and there will be a view whether we've seen an increase in safeguarding reports due to COVID. We have anecdotally heard, increased reports of domestic violence, neglect, that I'm sure will be coming out through our usual safeguarding route. So we'll keep a very close eye on that. Mark, you're absolutely right. We need to communicate much more to our population the services that are available and open. And I think through the first wave of the pandemic, some of the experience we saw with the reduction in referrals, I'm particularly thinking about IATs, we want to try and prevent happening as we go into winter and a second surge. So working again with Charlotte and her team to make sure that the NHS is still open, it's still there for you for mental health, as strong there for physical health, and actually that directory of services that not just for health services but also all the support services there for people with mental health, learning disability, autism. I think that's something that we need to look at. Again, I think there's something around doing that at borough level as much as doing it at South West London level, so I'll take that away. Dino was around the increase and the shift in presentations and noting the PTSD and giving the difference in presentations, and you're right, it's very different to what it was pre-COVID. I'm not a clinician, so I'll leave clinicians to have a view around how we make sure that we are tracking that change and the different types of presentations. But I think we are very much almost weekly, monthly, looking at our capacity and are we effectively meeting demand. And I think also some of this, and I think I said at the beginning, some of this won't be now. Some of these presentations will be in a year's, 18 months time. So how can we really get on the front foot around making sure that we have that capacity when people do start to come and present. Digital, I think there is a very fine balance to be had between face-to-face and ensuring that digital, where it is used, can be used. And it's actually the patients and the staff, about there are staff that are very nervous about moving to face-to-face, particularly with some of the client group can be quite challenging in their behaviour, and actually managing to work within a social distancing room and PPE some client times it is difficult, and we need to support staff to be able to feel comfortable in offering face-to-face for people with mental health and learning disabilities, but also support people where they can to use digital, whether that's in we talked last week, didn't we, with the leaders of the local councils around whether we look at councils being able to offer space on their office sites for people to access digital if they don't want to do it in their own home, or support to be able to do it as well. So I think that's something I would really like to explore. Dagmar, you mentioned testing. I'll put my other hat on. I'll take off my mental health hat and I'll put my testing hat on. I absolutely agree with you. I think we're seeing something coming down the line very quickly around non-symptomatic testing. We know there's a trial going on at Liverpool at the moment, starting I think on Friday, where the Army is going to support everyone in Liverpool to get a test. And we do know that I think we are planning to have the new fast testing, the saliva test, available in December. So we are I think there's going to be some significant change in that soon, and I'm coming to talk to yourselves, the DPHs and the clinical leadership group next week around how do we make sure that we're in the right place to be able to adopt those new technologies as they come online. I think, Bruno, you mentioned about the potential strain on voluntary sector organisations managing a increasing demand for people in support for their mental health and emotional well-being. And yeah, I mean, I need to have another think about that and actually work with yourselves and colleagues around how do we support the voluntary organisations to be able to work, because it's really important that we don't medicalise everyone's mental health, isn't it? So actually, whilst mental health services are there and they should be used appropriately, that's not always the right response to someone. And actually, the voluntary sectors have a really important role to play in ensuring that people's emotional well-being and mental health is kept where it very good. Sorry, so we've been talking a long time now. And your final point was the integration at borough level for people with learning disabilities. I would agree with you, it's variable across the boroughs. I know there's been some fantastic work in Sutton at the moment around how working with LD of the learning from that work to how we can more work with our local authorities, because particularly with learning disabilities we can offer a full service to people with learning disabilities and give them the support without that integration with local authorities. I'm going to stop now. I hope that's covered most of the questions adequately, but as I said, I'm happy to have the conversation offline. I'll come and talk to anyone who issues at anyone. Thank you.
Thank you, Tonya. Really helpful. I think you did an incredible job of covering all that in your response. So well done and thank you. And I note the offer that people can pick up with you outside the meeting if they want to talk about any of those things further. So thank you. That was really, really helpful. I'm going to move us on because that was for noting. I'm going to move us on to the next item on the agenda, which is a run through of the various different committees and functions that we hold as a CCG. So we're starting with Audit Committee, and Paul, shall I call on you to give a view of what's been going on in Audit Committee?
Sure, thank you, Chair. So since the last governing body, we've had two audit committees, one in September, one last month. So I'll just put a couple of issues from each committee, and I think from the first one in September, probably two things just to mention there. We discussed the contracts and procurement policy. So this is a new approved policy where all 6 CCGs are now integrated. So it's good now we've got a consistent set of policies presented by and he's also set up what's called the CPAG, or the Contract and Procurement Advisory monitor review procurement and progress there. So I think a big welcome to governance for the CCG. The second point I would raise from the September committee is a discussion we had around the conflict of interest guardian. And this was to, I guess, review and reconfirm the role of that conflict of interest guardian. And basically, it was to make sure that that role was visible. And I think it's been rolled out in training now as we speak, that if there are conflict of interest issues on a day-to-day basis, that's taken up with the governance lead. But if there's a need to escalate, then that comes to myself as the COI guardian to arbitrate on. So hopefully that has been communicated and is part of the training now. If I jump then to the October committee chair, the two items I would pull from that meeting. First of all, we had the first review of the risk register, and it was really a review of the work in progress that Ben had presented to date. I won't go into any of the discussions because it is actually an agenda item later, so can raise a couple of questions there. And the final issue, I guess, from the October committee was what we call the Finance Committee update, and this was just really to have a wider discussion around the ongoing uncertainty of the finance regime. And at the time we had the discussion, I think we were just finalising the plan to NHS England. We're still waiting for obviously the latest set of guidance for phase 4, but really I think it's just to ensure our internal auditors, our external auditors, they're aware of the risks, the uncertainties as we, start to head towards the year end, and making sure, the governance and the visibility of that is maintained, and that we're all aware as a governing body of what those risks are. So I think that was it, Chair. Happy to take any questions if there are any.
Thanks, Paul. Really helpful summary. Any questions or comments on audit at this stage? No? Okay. Thank you, Paul. Really helpful. So let's go straight on then to Finance Committee. We'll hear from David as Chair of Finance Committee, and then we've got the finance report that James is going to talk to.
Yeah, thank you, Andrew. So just to give the board a flavour of what we've been doing as a Finance Committee, so we've been continuing to review the performance of both the CCG and the overall system for the first part of the year. The second big area of work has been in relation to the plans that have now in with the NHS England for the second 6 months. So we've had a number of meetings in October when we've been going through those draft plans with James, the Finance Director, and he'll talk about more of the detail in a second. We've got later on the agenda the complex business case for mental health services, where we've made a recommendation as a committee, but we can come to that later on. And the other piece is around we're signing off single tender waivers. So that's some work that we're having to do as a Finance Committee to make sure that we tie up some of the loose end and some of the legacy issues that the CCG still has. So happy to take any questions on what the Finance Committee is doing.
Thanks, David. That's really helpful. What I suggest we do, let's go straight on to James's finance update, and then we'll take any questions relating to the finance update or what you've been doing at the Finance Committee in the round. So James, over to you.
Okay, thanks, Andrew. Just a quick update, really. So the report you've got up in front of you outlines the position at month 6. As you know, we've been working to a different financial regime for the first half of this year, where we have the retrospective top-ups, and this is the last month, month 6. So we've received all our top-ups to month 5. We're obviously waiting for month 6, which is going through the process, but I'm not envisaging any issues or problems on that. From month 7, we move to a new financial regime. So we've been set system envelopes. So we're moving out of a prospective retrospective position into a prospective position. So we've been set a system envelope, we haven't gone back to where we were before. So we're not operating traditional sort of CCG trust contracts. Those have been nationally set in terms of the amounts that the trusts will receive. But what we have received is a COVID top-up for the second half of the year. And the key difference really is that we're obviously expected to manage as a system within the envelope that we've been given. We've submitted a plan on that basis, which David talked or alluded to in his update. We've got a bit of a gap at the moment, but we've got a process for working through that and trying to resolve that. But clearly, in the current context and the changing picture that we've got at the moment, we're going to have to be nimble on that and work out how best we use the money that we've been given to respond to emerging issues, whether they be recovery, COVID, or managing winter. I think the key message of all of this is, though, that we can't retrospectively claim money back. So we're looking at how we manage a bit of, if I put it a different way, this way, a bit of financial discipline back into the system. And that's going to be one of the key objectives for this year, but also looking at next year and about how we exit into whatever next year looks like, because clearly we've had a lot of disruption to the service, and we'll be expected within the economic climate to get back into a more normalised process going forward. So it's really just to highlight that we will have to start looking at finance and value for money much clearer as we go forward. Just to give the governing body some reassurance, as David said, we're looking at all that through our own finance committee. So we don't just look at the CCG position, we look at the system position as well. We're also working through the Chief Executives group with all the stakeholders and the Recovery Board to highlight those decisions, and those need to come back through into the CCG committee. And we've also re-established or established now a sort of system non-exec finance chairs group, which again gives us a bit of a lead into to some different oversight across the system. So all of those things are in place. So just to give the governing body some reassurance that we're adapting how we work to the ways going forward. We haven't got any clear steer on what next year will look like, but clearly as that emerges, we'll bring that back to the governing body. And again, just to pick up what Paul mentioned in his audit update, we are in conversation with the auditors about what this all means when we get to the year end, given the phases that we've been through in this year, and it's been a very different and turbulent year, not just from the service, but a financial and a governance point of view, really. So I'll just stop there and take any questions.
Thank you, James. Really helpful. So, are there any questions or comments on Finance Committee and the finance update? I think it's worth noting it's a really complex context in which you're working, James, and a lot of uncertainty. I think you're doing a great job of holding that together. So thank you. Any questions, Dagmar?
Hi, it's really only just a comment, and Ian might want to chip in that obviously in the end there wasn't really a spending review, there wasn't a proper settlement for adult social care, so we will end up with a 1-year settlement in local authority for adult social care. And if we think as a system what that means for health and care really needs to be considered. We are expecting to hear what the ATRA settlement will be for local authorities probably sometime in December. So timing is very tight, and you will be aware about the very precarious situation that local government finds itself in with all the income issues, etc. So just a reminder that it probably needs heads together with some of the finance people in local government to see what does that mean for the next year in terms of integration, so that we really understand each other's positions and can work as a system as much as possible.
So maybe a question for you, James. When you talk about system finance, how broad is our concept of system finance? Are we largely talking about NHS finance across South West London, or do we factor in where we're at with social care, for example, and the position of local authorities?
Yeah, so clearly, you know, we've been very focused locally on the NHS point of view, but clearly the where there's overlap, in particular, you know, I'm thinking about some of the local borough stuff and the CHC. We need to think about that differently going forward, because Dagmar's exactly right. We've done some things differently through this year, which I think have worked quite well actually, and we wouldn't want to lose some of those. So, and there are implications for how we're working in the second 6 months of the year when you look at discharge and CHC. So we've got one of the recovery work streams looks at that. So we'll pick that up through that. So it's a point well made by Dagmar.
Thanks, James. And then Susan.
I was just really following on from that then. So I can see in our risk register later on, there's an issue around financial concerns. That's obviously a hot topic. Do you think the issue around the local authority financial instability is a risk that we need to articulate and describe how we're going to? I mean, it was interesting, the discussion that Matthew had earlier, wasn't it, about how he's working and sitting alongside Croydon in their particular issues, but you know, that would be it would just be interesting to know. I was party to that conversation, but it would just be interesting to know whether we should be putting more in our risk register around the relationship between health and care and the financial instability. I don't see it particularly articulated, but maybe not.
Yeah, we can certainly look at that, and I think that's a valid point. But I think, you know, there are opportunities as well as threats in this, so I think we need to look at it on a how do we work better together, as well as just looking at what the risks are. But again, it's point well made. So we'll pick that up. I'll pick that up with Ben.
Matthew, you probably wanted to come in.
Yeah, just on that point, if I can, Andrew, but very briefly. I mean, I think Susan makes a good point, as does James. I think there should be some reference to it, but I would agree, both as a risk and as a challenge for us, but also as an opportunity, and that's definitely how we're seeing it in Croydon. So, and it's been included in the Croydon Place risk register in the way that Susan suggested.
Thank you all. Right, I'm going to move us on to the next committee, which is Primary Care Commissioning Committee. Susan.
Hello, yes, I think you've had the feedback. Just to say that in line with our delegated duties, we've had to take a number of contractual decisions based on recommendations from the different borough committees, but also we had a really helpful presentation from Nicola and the boroughs to help us understand in a bit more detail the strategies we're putting in place to support practices around quality assurance and improvement. So I'd just like to congratulate the teams on all the work they've been doing. It was a very helpful insight, but that's all really, unless anybody's got any questions.
Thank you, Susan. So any questions on that, or any further comments on primary care? No? Okay, well, I shall move us on then to quality performance oversight. So to hear what the Quality Performance and Oversight Committee's been up to, Pippa.
Thank you, Chair. So you've got the report, and I'm just going to draw out a couple of areas, if that's okay. So I'll start off with performance. So we've had a conversation about the value added of QPOC as opposed to the Recovery Board, which is looking at a lot of elements of performance, as we've been hearing. We didn't, at our last meeting, see the whole performance report, so it may well be, if we've got questions about that, we deal with it after Jonathan's report that's following this. But we did do a deep dive into two areas. So we specifically looked at 111 performance and the SMI delivery performance. So just to talk about 111, and I'm sure that Jonathan will add to this in a minute. We had an update on the work that the CCG is doing to support the provider around this. As you'll see, there's been some variable performance over the last few months, and an increase in demand from the beginning of September. We were looking particularly at the timeliness of the call answering and the numbers of calls that have been abandoned. There is a lot of work that's going on, working with Vocare to ensure that we sustain our performance going forward and that there is sufficient capacity with the increased demands that are going to go on with this around the 111 First programme, which again we're going to hear more about later. So you'll see the work that's gone on there, and it is on our risk register. We then had a update on the serious mental illness health checks, and Tonia's already identified how very important this is. We had achieved this, we had achieved our target in Kingston, but there's more work to do in our other borough areas. We were assured that there is a task and finish group in place, and there's some focused work going on. There's an incentive scheme in place for general practice to encourage uptake in this, and obviously there's the complexities of this because of the environment that we're in now and COVID, but there's also because of that also an increased need for it to happen. So we've agreed that we're going to keep oversight of this, and we'll get a further update in February. The other areas that I just wanted to draw out was some where we are with our special educational needs and disabilities. So each area has got a SEND programme in place to support this very important group. We got an update from each of the boroughs. Very good progress in Sutton. So in my previous role, I was very familiar with the work that's gone on in that borough, both from a health and a local authority perspective to improve our offer for this group. And following the re-inspection, it's good news that there is no longer a written statement of action. And we were assured that all the learning that's taken place there is being shared across all the boroughs so that we can pick that up and make sure we're supporting people as we need to everywhere. Susan's given you an update on primary care. We don't look at this every time, but we are going to look at it twice yearly. I think probably the only thing to highlight here is that we did seek assurance around face-to-face appointments, and we were given assurance that there are plans in place, and where this is needed, it is possible for people to get face-to-face appointments. Flu update we also covered, but we've got that later on in the agenda.
Thank you, Pippa, that's really helpful. Why don't I'll suggest that we go on to hear the performance report from Jonathan, because he might pick up some of those issues you particularly referenced 111, and then I can take questions and comments in the round relating to quality and performance.
Okay, thank you very much, Andrew, and thanks Pippa as well, because that was a very helpful summary of where we are. I think obviously we're all aware of the public health emergency around COVID, but I think we're also becoming equally aware of the public health emergency around patients who have not appeared for treatment when they need it, or those who have waited a significant period of time. And that's a big focus of the performance report this time. After a significant amount of elective activity was stopped through the first wave, you can see in month 5, so in August, which is the reporting period covered in the report based on national validated data, that we're starting to see an upswing and an improvement in terms of returns to business as usual, so delivering the same levels of activity we have done historically, and that we continue to monitor that on a weekly basis just to give people some reassurance around that, and we're making major progress. So Matthew, much earlier on in the meeting, was talking about 120% of activity on a number of elective pathways at Croydon. Overall, we're very close to delivering 100% of BAU activity, 99% for outpatients for last week, around 90% for all elective activity, and we are the best performing sector of the capital in terms of our return to business as usual. I'd also call out the cancer performance piece, because we're aware of the significant number of patients who did not come forward through sort of Q1 and into Q2 for cancer treatment for a range of reasons, and you can see that we're doing well at getting 2-week wait referrals back. We're also doing well at treating the tail of long patients waiting. So there was at one point touching 104 plus, sorry, touching 400, 104 plus day waiters. That's now at about 100, and ongoing progress is being made there. Tonia's talked at length about where we are on IAPT access. I think we should be very proud and pleased with the progress that's been made around IAPT access. Richmond as a borough is already exceeding the national performance ask, and most boroughs are recovering, or all boroughs are covering at a significant pace. So I would draw the board's attention to that. The performance remains strong. We'll talk in more detail about 111 first in a moment. The area that Pip has already called out that had a tricky September particularly was 111 performance when the schools went back and there was a surge in demand, often at hours early in the day that the provider were not necessarily geared up to address. We're continuing to work with Vocare to ensure that they can deliver the 111 first model, and we have good progress at appointing the 25 call handlers and the 8 clinicians we need to do that in Southwest London, and we're also talking to other organisations about how they may help us provide greater resilience to that service over the winter months. So that's probably a few headline areas. We've talked a lot, Andrew, haven't we, about performance as we've gone through the rest of the agenda earlier. So those are probably headline areas, but very happy to take any comments or questions that people may have.
Thanks, Jonathan. Really helpful. I think you picked out the pertinent issues there as well in a really concise way. So any questions or comments on any of that from the board? So David?
Yes, thank you, Andrew, and thank you, Jonathan, for that explanation. The only time I get to see the detail on the performance is clearly through these meetings, and obviously other colleagues see them through the QPOC. The difficulty I've got with the report is that I find it really hard to pull out of the report what are really problems and what are the things that we're doing well at. And I have to say, what Jonathan has just said and that explanation, I think, was fantastic. It was really good. It told me what we're concerned about and what we're doing. And Jonathan, if there's just a way to encapsulate what you have just said in the report, I think that would really help, because otherwise I think there's just so much detail that I get lost in it. Now, I don't know whether that might just be a personal thing, but that real flavour that you have just given in terms of what we're concerned about and what we're doing, if you can get that in the sort of in the covery report rather than a series of bullet points, I think it would really just help to focus our attention as a board. So that's my plea really to Jonathan. I'll leave others to pick up any detailed questions.
Thanks, David. So, Jonathan, what I'll do is I'll just take all the questions and comments, because there's quite a few hands up, and then maybe if you want to just make a note and can come back at the end, like I got Tonya to do earlier. Is that all right? So, Pippa, back to you.
Thank you. So, Jonathan, as you know, our last QPOC, we didn't see the full report. So, absolutely agree around the really good work that's going on to get us back to our business as usual position. The only area, I suppose, that the report drew out for me that we need some further information on, you may want to bring it back to QPOC, is the diagnostic position. and where we are with some of those diagnostic procedures, specifically non-obstetric ultrasound, echo and endoscopy. So a view on how you want to sort of deal with that and give us assurance going forward would be helpful.
Thanks, Pippa. Les?
Yes, thanks very much, Jonathan. I was really wanting to ask about the strategy for dealing with the breast screening backlog. I mean, as you mentioned in the comments, it has been labelled as a priority for South West London. And clearly this is going to be challenging, as it goes back slightly to Pippa's thing about the difficulty with getting diagnostics done and reporting as well.
Thanks, Les. Matthew, let me come to you.
Thanks, Andrew. I was actually going to make a slightly different point on the back of the quality aspect of the report as opposed to the performance, but I would endorse what David said. I thought Jonathan's summary was excellent. But on the quality side, I think it's worth just flagging a Croydon issue linked a bit to mental health. So I was going to raise it in the mental health section, but as that was a slightly different conversation, I thought better here, which is that the trust in Croydon has had a CQC visit with regard to mental health care in emergency department. That follows a tragic case recently, and the CQC have written with an improvement notice, which the trust has responded to with a detailed action plan, and pertinently for this board has instituted a review, which the CQC were keen for us to do, and we agree it would be a positive step, and that review will be into how mental health care is provided in the emergency department. Obviously, underlyingly, one of the issues here is that there are an increasing number of mental health presentations to emergency departments, and in the Croydon patch, which is provided by SLAM, some challenges with underlying capacity in the system, and so the trust and South London and Maudsley Trust have jointly commissioned ELFT, so that's East London Foundation Trust, which is a mental health trust up in North East London, and Lewisham and Greenwich Trust to support us in this review, which will be jointly sort of owned by SLAM and the trust. And obviously we've also ensured that South West London CCG are participating in that review, and that's why I thought it was worth flagging it here, Andrew, so that there is full sight of that by the governing body. Just discussing exactly how the South West London CCG input will be formulated, but that's a bit of detail. But the important point is that this is something that the Croydon system obviously sees very seriously, and wants to make sure that we're taking every opportunity to improve that care for our mental health patients whilst they're with us in emergency care, and we think this is a positive way of doing that, and I thought it was important just to reference it here at the governing body.
Thanks, Matthew. Let me just come on then to Liz. So final question from you, and then I'll come back to Jonathan.
Thanks. Yes, the Health Watch points that I want to pick up, and we discussed them to a certain extent at the pre-meet yesterday. Firstly was the capacity issue in relation to the 111 First pilot, particularly in the light of the pilot very rapidly moves on to the early adopters, and for example Kingston has already started, so wanting assurances on the capacity issue, given that it is flagged up particularly on the risk register. The second point in relation to this paper in general is it's a very, very rich source of data, and that's very useful. But we will want to discuss the issue of patient and public involvement more widely. Firstly, I think in relation to the huge changes that have occurred in the NHS and the extent to which people are aware of them or have a view on them. And secondly, I guess when we come to that agenda item in relation to this change in A&E provision. And one of the things to note, and I think Pippa picked this up earlier, about being more systematic about how the patient and public involvement is planned and also is recorded, because I'm not sure that it's terribly systematic at the moment. And in fact, the cover sheet for this particular item, I'm afraid, is erroneous. It hasn't had any PPI because it didn't go to the ICS board. We think it went to the recovery board, which of course doesn't have any PPI on it. So that this very detailed and very useful report hasn't actually had any PPI until it has come to this particular meeting.
Thanks, Liz. So look, there's a number of issues there on the patient and public involvement in service change and overall kind of system scrutiny. I might just Charlotte Gorn, I might ask you to come in at the end to kind of support the answer on that. Jonathan, over to you. But what I'd say, two things probably to say. One is, let's leave the question about the 111 pilot to the item we've got on the agenda in relation to that. The other thing is, two of the key issues that were raised from the performance report, diagnostics and breast screening. So breast screening, which forms part of the broader cancer screening agenda. I think it's really important to flag up that as part of the COVID recovery approach in the South West London integrated care system, we've got a specific recovery programme looking at diagnostics and a specific recovery programme looking at cancer. Both those areas we have to report up to NHS England and improvement to provide assurance there, and we're seeking assurance through those programmes to the recovery board. So I think a really important question about how we work as a system is probably making sure that we're not doing too many assurance in too many different places, but it is really quite critical that the Quality and Performance Oversight Committee of the CCG is at least cited on what is going on in these different settings and the degree of assurance that's being given there, so that we don't duplicate, but also so that we make sure we're picking up any gaps in system assurance and oversight. So we have had a bit of a discussion previously about that. I think it's just worth making that point in public. So Jonathan, shall I come on to you to work through some of that?
Okay, thank you. So I'll try and whiz through those and describe where I think is probably the best setting for their reflection. So thank you, David, for the comments on the paper. So happy to talk with you outside. That would be helpful, and also happy to share the paper in advance for the governing body if people would like to see it, so people are well sighted what's going on. In terms of the diagnostics piece, then I think Pippa's right. It would be good to discuss that in UPOC, and as Andrew's also acknowledged, we have a diagnostics board that's overseeing this piece of work, so that's helpful to have some representation from them at the conversation. I would say, in the same way we've seen a major improvement in return to business as usual for elective and day case activity, we've also seen it for diagnostics. So there are some areas, for example, some scoping procedures where we're over 100% of BAU activity, but Pippa is right, the areas that were a challenge pre-COVID, such as non-obstetric ultrasound, such as echocardiograms, remain an issue, largely around workforce actually, but remain an issue now. So we ought to remain cited on that. But that would be my response to Pippa. Let's pick that up in QPOC. On screening, I'd start by noting that we've made, I think, really significant progress, and got to remember NHS England's commissioning role around this, but really significant progress on cervical and bowel to get those services back up and running. But we do have further to go on breast screening. My understanding is a business case has been approved to support that through NHS England. And we were having quite a conversation internally last week about how we geared up the comms to encourage women to come in for their breast scans. The piece of work I'm doing at the moment is just checking to ensure that we have the staff at the service base at St George's to respond to that increase in demand before we press go on that. But it's a problem across London, and it's a specific issue as well for us. And again, very happy to talk to QPOC or wherever where people feel they want to. As you said, Andrew, I won't pick up the 111 first issue here because it's on the agenda later, but I would acknowledge that just flag that the South West London is the first patch where all 4 trusts are now live with the new model, so I think that's a really positive thing to draw on. And Liz, the comments about public and patient engagement, I think they probably relate, rather than to the specifics of the performance report, they probably relate more to how we've been tackling the phase 3 response, which is a little bit further on the agenda. And so happy to pick it up there. And Charlotte, as Andrew said, may also want to comment on that. So maybe it's easiest to pick it up in that setting. We did talk about it at the programme board, but let's cover it in that agenda item would be my suggestion. So I don't know, Andrew, whether you feel I've done at least reasonable justice to the array.
Sterling job there, Jonathan, because there was quite a big array of questions. So thank you for that. Charlotte, you can either come in now or later when we do the planning update in response to phase 3. Don't know when you would like to speak.
Do either, Andrew. We'll take your advice.
Do you want to say something now, and then we'll go on to the next section?
Yeah, so I suppose just about our approach to kind of patient engagement and transparent communications during a pandemic. So I think, obviously it is more difficult than it has been kind of in normal times, but we have worked really hard, and Healthwatch have been brilliant in coming together with us to have a collective view so that we can understand people's experiences, both in communities and our patients during the pandemic. And as you know, we did produce a big kind of report at the end of the summer, bringing together, within boroughs and 4 work streams on kind of patient feedback and insight during the pandemic. And I think, in times of service change during a pandemic, when we have to make essential changes for safety, for patient safety and for staff safety, it is difficult to do the same level of engagement work as we would normally want to do. But I think the approach that we are going for with the recovery board is looking at the impact on those essential changes on our patients and for our community. So whereas before we might do a lot of engagement on should we make this change and having that insight before we make a decision, often during a pandemic we have to make the decisions quickly, but we are doing engagement on the impact of those patients that are affected. So I can give you one example. So within every work stream that reports into the recovery board, we have a engagement expert sitting in those recovery work streams and feeding in the insight from patients and community. So if I take mental health as one example, so we know we've had to move into a more digital way of working for mental health, and a lot of that has been unavoidable, but the insight work has told us, that many children, for example, not many, there are some children, for example, that find the online counselling sessions difficult because they don't have a private space at home. So that's an example of where we can then look to adapt the services that we are providing during a pandemic, and where the insight work can really affect the kind of planning of the services going forward. So I think working together with all our health and care partners, we have a lot of insight work, and we're trying to do that engagement on the impact so it can feed into planning.
Thank you, Charlotte. That's really, really helpful. I think you and your team are doing an incredible job of holding that together, and I know that there's thinking going on about how we enhance that further moving forward, particularly as some of the changes we start to look at we've got a bit more time to do. I'm going to move us on because we need to try and get through the agenda. In this section we've still got a verbal update from Remuneration Committee to come, so David, let me turn to you for that, and then we will be moving on to the planning update. David, were you expecting to give a verbal update from Remuneration Committee? I can't hear you and I might have lost you.
Sorry. Yeah, no, I'm back. Yeah, so the Remuneration Committee, we're continuing to meet. The main piece of work that we're doing is in relation to the pay framework and employment framework for clinical leads. So there's a number of discussions. We had a meeting earlier this week to review where we're at on that, and a paper will be produced very shortly for a wider consultation. So that's the main piece of work. The second bit we're doing is really just now finishing off any of the issues relating to the bringing of the 6 CCGs together into one.
Thank you. That's helpful just to be cited on what's going on there. Right, I'm going to move us on to section 7, planning update. So Jonathan, back to you.
Thank you very much, Andrew. So I think one of the critical asks that the NHS was asked to deliver through the late summer and into autumn was a response to the challenges set out in the phase 3 letter sent by Simon Stevens. There were really 3 core components to that. The returning to near normal levels of activity, and we've already spent a bit of time talking about that, but particularly in the window of opportunity that was available to us prior to winter. Preparation for winter demand pressures, and how we would deal with any subsequent spikes of COVID, which of course we are now experiencing, and taking account of any lessons learned through the first peak, and how we support our staff through this and all the challenges that we've had through that time. So there was an immense amount of work done. A lot of it was done in late August, when not everyone was available, and into early September. So I imagine, to Liz's point, it would have been great if we could have had even more stakeholder involvement. There was extensive engagement through the Recovery Board, and I did present this at the Programme Board too at the last meeting. I know the focus of the meeting was on health inequalities, but I did present the papers, and colleagues have had an opportunity to review them. So I guess key points to note in the extensive planning document, and we went further than the planning ask, which was really around how we started elective care, how we maintained urgent care, and also how we addressed some of the mental health components to other areas of what we do, including primary and community services. But the key points to note were, we were asked in this plan to assume no substantive second wave of COVID. Of course, subsequent to that, that's what we're experiencing, and there's further planning work going on about how we manage things like ITU and general and acute bed capacity through this period. We were asked to set out, as we've talked about at length, how we're going to do on elective and diagnostics, and after an awful lot of work, we collectively got to a place of being able to deliver those standards across the system, which is an enormous achievement, both to plan for it and then subsequently to deliver it, which is what we are doing. And to give you a very clear example of that, our 52-week waiter, so people who have waited more than a year, is currently half of what we expected it to be just a few months ago. So that's testament to all the hard work that is taking place. We've also talked about the shift of 111 to 111 first, and the expectation of 20% shift of unheralded patients, so patients who previously would have arrived at the A&E department going through 111 first. and the plan also sets out a detailed set of assumptions around how we will build the workforce that we need in order to deliver these plans. So that's probably, by way of very, very brief summary, Andrew, a reflection on an immense amount of work that took place across the system through the late summer and early autumn. Very happy, probably better since given time for me to pause and take any questions rather than wade through a very long slide deck.
Thanks, Jonathan. So, I mean, I'll assume people have had a chance to look at the slide deck, and if they wanted to look at that in detail, I've had an opportunity to do that. So, shall I open it up to questions or comments for Jonathan? Well, I think you might have so effectively presented, you've preempted any questions or comments and answered them in advance. And obviously we did have a discussion about patient and public involvement, and I think we've discussed that in the prior section. So good, that was very helpful. Thank you, Jonathan. I will move us straight on then to the next part of the agenda, which is an update on flu. So Tonya, over to you. I know you've got stuck out at past to have a London meeting on vaccination, but I'll let you get going.
Thank you. Did you want to project the presentation, or are you happy to talk to it? Shall we project it?
Well, if we can project it, great. But
I'll start, and if it comes, so I'm really pleased to be able to come and talk to you about the rollout of our flu vaccination program for this year, because actually it is a good news story. So I have a regular update with Fergus, who is working on this operationally, and I had that this morning, and I had some really good news in terms of our progress. So, and I want to begin by thanking everyone who's worked so hard to have a really good, strong delivery on the flu vaccine. So, in terms of the cohorts, and if you go to the next slide, you can see the cohorts. We are ahead of London in all our cohorts. We're the first and ahead of London average and first in many of them, and we're ahead of the English average except one, which is always a bit galling when there's one, and that's the over 65s, but we have seen a 20% increase in last year's vaccine uptake in the over 65s. So we're ahead of England, ahead of London in most of the areas. We're also doing staff, and South West London St George's, I will identify them because they are the best mental health trust in London for uptake of flu vaccine. So some really strong performance there. And if we carried on, you should remember the flu programme is a 3-month program. We try and finish, there'll always be some that happens afterwards, but we always try and finish at the end of the calendar year on the 31st of December. And in 2 of our areas, the under 65s and 2 to 3 year olds, if we continue at the rate we are going at the moment, we will over achieve the 75% target for those cohorts. That's really good news. I suppose the risk around this is the vaccine supply, and our continued performance is entirely dependent on stocks, and it still is an issue, and it's fair to say that it's probably not being resolved as quickly as we would like. But I think in generally it's a really good news. I mean, when we started planning for the programme, we were very worried both about the workforce capacity to be able to deliver the programme, but also the population's willingness to take the flu vaccine, and we've seen some really strong demand for the flu vaccine. So that was just my introduction. So a quick overview. A lot of you will know this, so I won't dwell, but just to know that we have extended the eligibility cohorts this year, particularly around the age group 50 to 64. We still haven't had the green light to do the 50 to 64 cohorts. So if you remember, this is a general population vaccine approach. So if you don't meet the other eligible criteria, there would be a push to vaccinate everyone over the 50 to 64-year-olds, and we still haven't had the green light for that one. The other areas of new this year, so they've extended the school age cohort, so year 7s have now been added this year, and obviously the new household contacts is there as well. So that's the cohorts that we're working with at the moment, and you can see the targets are around 75% for all cohorts, with 100% for health and care and social workers. Next slide. So if you take the whole of the cohorts together, including the 50 to 64s, our target would be to deliver 700,000 vaccines. That's roughly double previous years. And you can see a breakdown by the cohorts there for information. Next slide, please. So our ambition in South West London is not just to meet the target, but actually to see, for those across all clinically indicated groups, to not just meet the national uptake ambition, but to improve on previous year's uptake. And those are, you can see the list that we're targeting. Absolutely, we need to get to our high risk groups and all our health and care staff. Actually, with the health and care staff, this Saturday we are piloting in Kingston a dedicated service clinic for domiciliary staff. So we've agreed with the council that we will use some of their premises. We have community pharmacists going in to offer free vaccinations to domiciliary staff, because they are quite a difficult a group to vaccinate, particularly around accessing community pharmacists and GPs to be able to receive the vaccine. Next slide, please. This is delivery plan. I won't dwell on this. You can just see that we're on track, and we have had our peer review, IHCS peer review across London. It was really interesting exercise. We were able to showcase some of the good work we're doing in South West London that other ICSs are now adopting, and we're also to be able to still with pride other areas, what other areas are doing where we think it would be useful for us. So that was really good. Thank you. Next slide. So our South West London plans, to say many GP practices have commenced the vaccination, and through November we'll start the high risk patients once vaccine is delivered. Community pharmacists have commenced advertising and administration for all age groups. Schools are back open and children's vaccination has commenced. And we did the peer review process, which I've just talked about, and we're improving data, dashboard and information flows for oversight delivery. And we share that dashboard information regularly with partners to show how we're doing against our trajectories. And we get feeds in from London as well around some of that. So we get the NHS staff feed. We also get the school feed from NHS England. So we have a complete picture of the vaccination uptake in South West London. Next slide, please. Bruno talked about the insight work right at the beginning of the meeting, and it's proved invaluable to helping us plan for our flu programme this year, and actually Valentina in Charlotte's team and the whole team has worked very hard on this. And using the insight work, we've been able to tailor our programme to make sure that our most vulnerable populations can and will try and access the vaccine. I won't go through it in detail, but you can see there the things that I've said and what we should be adopting. Next slide, please. And these are the actions that we've been taking forward to make sure we target those priority groups, such as making it easy and timely for people to get their vaccine, some bespoke work, particularly around the BAME. And I said in my previous presentation that we're using some of the transforming money that we have for LEDA, the mortality reviews for learning disabilities, to target flu vaccination in that group, recruit clinical flu experts, and also some of the learnings through the mobile test and trace. Next slide, please. So we've obviously had to make some assumptions and dispensancies when we're doing our planning. So we've had to assume that vaccines are arriving on time, that the workforce is in place, that current COVID-19 restrictions and government guidelines don't change and remain in place. You can tell that this presentation was written a while ago, because it talks about being in tier 2. We obviously know that will change, and we'll have to make sure that our plans reflect the change in the restrictions. That we have flexible estates, and we've got some really good examples where that flexible estates have been used in South West London, IKEA in Croydon and also Crystal Palace. And we have a well-developed communication strategy, which is really important to make sure that we get those numbers up for those hard to reach groups and high risk groups. Thank you. Next slide, please. I won't go through this in detail. This is our risks, and the two highest risks, as I've talked about, is vaccine delays and the impact of a second surge and lockdown on delivery, which we'll have to monitor carefully over the next 4 weeks. Next slide. So we have really strong oversight. We have an SMT oversight, so we really try and do this monitoring on a real-time basis. Our dashboard allows that, and we share that through our partnerships, and actually practices can also see that dashboard for themselves and can use it to target cohorts where the performance needs to just be a little bit focused. Next slide, please. So this shows the vaccines completed in practice up to the 22nd of October. So this will already be out of date. It's such real-time data that we're using. But you can see here that at the 22nd of October, just over 127,000 vaccines had been delivered by primary care. And we just wanted to give a special mention to those practice where the over 65-year-olds target is well advanced and it is being achieved and on the target to be achieved. So thank you to those practices who have been able to manage to do that. Next slide, please. This just shows you a breakdown on the left-hand side, you can see the breakdown of the percentage for community pharmacies vaccines in London, and you can see if this South West London is the second highest performance in the number of vaccines delivered by community pharmacists, which is really good news. And then on the right hand side there's a table that shows you a breakdown of NHS staff in provider organisations receiving the vaccine, and currently when this at the 22nd October 42% of staff had been vaccinated. Next slide. I think that might be the end. Could be wrong. I think that's the end. I hope it's the end, but I'm happy to take any questions.
Let's assume it is. Thank you, Tonya, really helpful. And again, there's a huge amount in there. So let me open it up to questions or comments. Bruno.
Yeah, I've just got one question. That's in relation to whether, in terms of immunising health and care staff, voluntary sector subcontractors, where they're busy doing equivalent roles to those which might be done in mental health trusts or other trusts which are providing social prescribing, whether they would be counted equally and be a priority also. Because I know that prescribing is sometimes subcontracted out to the voluntary sector. In addition, some mental health services and that mental health provision, and that those are two areas where pressures in one part of the system may feed into others if the flu, if there is actually a flu epidemic this year.
So Bruno, the definitions for health and care workers to receive a free vaccine are very set nationally, and they don't include voluntary workers at the moment. So just to give you an example, the definition of frontline workers don't include CCG staff either. So it's very set nationally, and I think it's a fair point which we can raise, but it's not part of the cohort that are offered the free flu vaccination at the moment.
Yeah, I think it would be helpful if that were raised, because we do know that there's a contribution made there and that it does take pressure off other parts of the system, and that there are people who are working effectively in equivalent roles there. Thank you.
I think that's a really valid point, particularly for those who are still doing face-to-face activity. So, Agnello.
Yeah, no, I think the presentation was great, and it really does show some really positive results so far going forward. However, we had a meeting yesterday with clinical leads as well in Croydon, and Croydon has always been two parts of a borough, couldn't be dissimilar. So in terms of where you've had white affluent populations, the uptake of flu has been really good. However, the reports in areas which have high BME population, over 70% of BME population, think uptake is really poor. And practices are really struggling to convince people to have the flu jab, whether even by offering all the Crystal Palaces and the IKEAs and the practices and everything else. So I think how as a CCG can we prevent widening of health inequalities by being able to focus on those populations in those areas to help support the vaccination program, because it's a real concern that we may have we're having difficulties with the flu vaccination, but we'll have the same difficulties with the COVID vaccination in the same cohort of people, because there's the comms team is fully aware of the myths around and the fake news and the suspicions about flu vaccination and the situation at the moment. So the reality is that we need to do something proactively with this population.
Thanks, Agnella. And Dagmar, was your comment on a similar vein?
Yeah, it is, slightly different, but I think fits in here. So from a purely epidemiological point of view, probably where we are with the social distancing going on and the learning from what happened in Australia with flu, the group with the highest risk to spread flu are the kids. They are super spreaders. They don't get that ill, but they are super spreaders for flu, quite different to COVID, and they go to school where there is still mixing. So if I would say from a pure spreading the flu around point of view, where we should have another real push is also not to forget the kids. But I think, Agnello, your point is very good in terms of priming us and learning from the flu vaccination how we can engage communities that are suspicious and not taking up the vaccine. But in pure terms of impact, it's the kids for the flu.
So, Tonya, I can see Charlotte's hands up, and I'm sure she's going to want to come in on the issue of those particular groups and the work that is going on around that. But shall I, Tonya and Charlotte, between you, do you want to handle?
I think Charlotte would want to lead on this one. Thanks.
Okay.
Shall we go? Yes. So Agnello, of course, is right about the flu vaccine uptake, and you'll know from the insight work we did with over 4,000 local people that kind of enthusiasm for the flu vaccine is overall very high this year, and actually higher than previous years. But there are issues within some of our Black, Asian and minority ethnic groups around concern and anxiety around the flu vaccine this year. And the way to change people's behaviour and people's perceptions is, yes, we can do all of the kind of broadcast communication. So we're doing lots of films locally, putting out lots of messages. But the real way to change behaviour is by the conversations. So engagement leads are working with the South West London Flu Group, so with Tonya's team, with local clinicians, to have conversations with communities. And I know Sutton, so Dino has done particularly well in Sutton very early on in having conversations with those groups and really changing people's minds. So it is very kind of time and labour intensive to have individual conversations, often with quite small groups, but we know from the work we've done so far that really does have an impact. And this will be the same with the COVID vaccine, won't it? So it's conversations from clinicians and leaders like yourselves, but also with community leaders. So we're doing lots of work with community leaders in each borough to talk to them about their anxieties and their particular cohort of that population's anxieties about flu. And then they are then spreading the message within those particular groups. So I think it is a kind of job of work, but we can have a real impact when we have those kind of face-to-face or virtual face-to-face conversations.
So Charlotte, that's helpful. There might be something outside the meeting in just making sure that the team working on engagement in Croydon has the conversation with Agnello, so we can make sure if there are specific Croydon issues that they're picked up. Agnello.
Yeah, so picking up Dagmar's point and Charlotte's point, so if children are the super spreaders, in terms of comms, can we not target children to take back information to their households? We know that children are the biggest influences on their families.
Yeah, we can definitely think about that. I guess it's, yes, should we talk about that outside? That might be a good idea, mightn't it, going through the school route?
And then Bruno?
Yeah, it was just a very short follow-up in relation to my previous question, because I think that you said that CCG staff aren't a priority, certainly nationally. I understand that, but certainly from my work in Hammersmith and Fulham CCG, the CCG staff there are getting vaccinated. So I wondered why it might be if South West London isn't doing that, because although it's not going to have an impact on the epidemic amongst the population, should there be a flu epidemic, clearly, you know, it's beneficial to the workforce of the CCG if they have that availability.
So we are supporting CCG staff to get the vaccine. They just can't get free vaccine. So we reimburse people for the cost of the vaccine if they go to Boots or community pharmacists. It's the access to the free vaccine. So health and care workers, if you're key line, it's free. Everyone else you'd have to employ is reimbursed, and that's what we're doing in CCG.
Yeah, okay, thank you.
So we're encouraging our staff to take the vaccine.
So, Tonya, there might just be a further conversation outside the meeting with Bruno and the voluntary sector, just thinking about how we can support the voluntary sector better. I know you're going to feed.
I will do. It will be the funding of it, won't it, Andrew? I think that's the thing, is that it's not automatically free to all workers.
Yeah. Sarah, you've got your hand up.
So it's for individual organisations to make that decision. At the moment, it's free for frontline NHS workers, and that is appropriate. We have decided to support our staff. Obviously, other organisations can do the same thing, but that is their personal decision. It's not an automatic. The NHS will fund everybody to have their flu vaccine. We fund those that are in high risk groups. We fund those that we know nationally should be vaccinated, and we vaccinate frontline staff. That doesn't mean we shouldn't support our staff, and we do in South West London, but it is set nationally who is funded and who isn't.
Thank you, Sarah. So I'm just going to pick up a couple of the comments in the chat, and then I'm going to move us on. So Dagmar was just saying that local authority staff, including school staff, are being encouraged to take the flu vaccine and then being reimbursed. And then Nicola's point was it's not just a Croydon issue around BAME communities, and I think that was what Charlotte was referencing. There is a focus pan South West London on BAME communities, but I think if individual chairs want to have a conversation outside the meeting with Charlotte and team, that I'm sure that they would be happy to do so. So let me wrap this one up. Thank you very much, Tonya. Really comprehensive update and really good discussion. I'm going to move us on to talk about the 111 pilot, which has been referenced a number of times already in the meeting, so it would be good for us to go through that.
Hi Andrew, and very happy to do so, and if Anne wants to show the slides, then I can crack on. I should just say that I have a number of people who are on this call who are part of the work on this, not least Agnello, Jonathan, Nicola and Dino, so if I say something that is wrong, I have plenty of people to remind me, but also they will be able to add if there is anything further they wish to comment on. So I won't go through every point on every slide, Andrew, but if we could move to the next slide, I will do the headlines to each of them. The 111 service, which is at the base of this programme, obviously is an important part of our health service provision, and it saw during the first part of the pandemic a very significant increase in the volume of calls to NHS 111 and the use of NHS 111 online, and at the same time we also saw a reduction in attendances to the emergency departments. That started to sort of revert in terms of those ED attendances over the summer. And the levels of attendances are steadily returning. I can certainly attest from a Croydon perspective that those numbers, particularly on the adult side, recovered quite quickly. It's taken longer on the children's side, interestingly. Now, the purpose of this piece of work, if we can move to the next slide, is to think about an alternative or an additional way, I should say more accurately, for patients to access emergency healthcare. As it says here, this is a national piece of work, and I'll come back to that when we talk about patient engagement. But on average, 70% of ED attendants are made up of walk-in patients, and there was some interest in seeing whether or not there could be different, better, additional ways that patients could receive emergency care. And this idea of the Think NHS 111 First approach was hit upon as one of those mechanisms. And really, it's about, in short form, streaming non-urgent patients away from emergency departments or urgent treatment centres into other urgent care settings. So that might well be primary care triage lists, it might be a pharmacist, it might be in a GP hub, as we have in Croydon and elsewhere. And the whole idea of the NHS 111 First programme was to try and get a broader approach to this, to offer the patients an additional route, and secondly, to reduce footfall into emergency departments. Because there's some clear benefit from patients going to what would be a better, more appropriate place, and secondly, because they are very mindful of reducing the risk of hospital acquired infections, and with large numbers of patients with various states of COVID positions in waiting rooms in emergency departments, there was felt to be a not inconsiderable risk that they could become areas where infections could spread. So that was the rationale behind the idea. If I can move to the next slide, that'd be great. And that basically just sets out what we are trying to do here across London, in that there's a whole range of services that happen through 111 at this moment, but these innovating sites to try to implement a new way of working has been added to that range of services. I'll move on to the next slide, and please. So just for completeness and in summary, what the NHS 111 First concept is an ability for 111 call handlers to book an appointment in the emergency department, that they can do that directly, and therefore to spread out, as I said earlier, this demand for emergency care into a better range of places. NHS 111 or a general practitioner is the first place a patient may contact, and what we are trying to do is reduce the need for a patient to go to that emergency department for accessing healthcare, and to look at alternatives. Now, it's really important, particularly from a patient perspective, that this is an alternative, not this is the only route that you can get access to emergency department care. And that's something that I know from a patient experience and patient understanding perspective is really important. So if I can move on to the next slide, that'd be great. So we've got 4 sites in South West London, obviously, where we will do this booking of patients into a booked slot at an emergency department, urgent treatment centre, or other venues for emergency care. That started off first and foremost in Croydon, just as the early sites. We did that in September, and then in October we've added Kingston, St Helier and St George's. That is put, as Jonathan said earlier in the meeting today, South West London as the first part of London that's got this pilot running for all of its urgent care sites in terms of the emergency departments. It will be rolled out across the rest of the calendar year in the remaining sites across London. If we can move on to the next slide, Anne. As part of this, there's been a very significant amount of assurance, and I think that's important because whilst this is an additional rather than a alternative only approach to accessing emergency care, it is important. These are patients who are phoning a system whereby there will be some more different access points provided, and therefore it's absolutely appropriate that we have proper sign-off. So that started off with a local sign-off in each individual A&E delivery board. That then went up to the system, so the ICS level review. It then went on to London-wide sign-off, and finally for the first sites a national sign-off too. And we received that, and indeed were able to proceed through that process, I think, well, and that was down to the hard work of each of the individual areas and the leaders within those areas, clinical leaders supported managerially, which is the way that this process has taken place. Move on to the next slide, please, Anne. Just as an example of what we're doing operationally in Croydon, we're running between 8 o'clock in the morning and 5 o'clock in the afternoon these book slots where patients can be booked in for those attendances. It's across both the emergency department and our urgent treatment centre. So if you phone 111, you're from Croydon, you can get that book slot in either ED or UTC. Obviously, from a 111 perspective, you can also be offered slots elsewhere. You can be put on a list for GP triage. You can be offered access to a pharmacist. It is not just emergency department and urgent treatment centre. But if you do book into one of those slots in Croydon, which we started from the end of September, we are now able to see you in this new way. And now, interestingly, we've seen, to start with, a relatively slow uptake of those slots. It increased over the first few weeks to about 25% of those slots being used on a daily basis. The latest data would suggest that's increased, and we're now, the last week's data was just under 40% of those slots being used. So that's showing an increasing level of awareness and willingness to use those slots by 111 and the patients, and certainly the feedback we've had thus far from patients is that they do like this process whereby they can book into a slot. It reduces their waiting time and can help the emergency departments plan a little bit more their work, and as a consequence focus their energies both on these groups of patients but also those sicker patients who may need more time and more input than these relatively more minor conditions that we're seeing through this 111 process. So we're up to just over 35 between that and 40% on utilisation at the moment. We keep it under regular review, and that's managed through the South West London Urgent Emergency Care Board, which a number of us on this meeting are on, and I'm sure others will want to add further to what I have said. So that's where we are at this moment. I think it's an interesting and important initiative. It's part of what a number of us have wanted to do for some time, which is to get into real transformation of urgent emergency care. And this is, I think, a positive first step towards that. I wouldn't say it's the only thing that we would like to do, or indeed the only thing that we should do going forward, but it is a positive development and shows that through the pandemic we can look at different ways of working and get benefit to patients, to the system, and indeed to our individual organisations and pathways, and we should be positive about that and build on that success with future transformations, which we're keen to do going forward. So that's probably all I need to say, Andrew, by way of sort of brief run through of the key elements of this pilot programme, and happy to take questions, and I'm sure Jonathan and other colleagues will be able to either add or help answer those questions.
Thank you very much, Matthew. Really helpful run through of that. Jonathan, do you want to come straight in?
Yeah. I just thought it would be worth being sort of transparent with the governing body that when we did the regional assurance part of this process that Matthew's outlined, which I did with the regional medical director a couple of weeks ago, I was very clear that we were experiencing some challenges with our 111 providers. We've talked about earlier in the meeting, and we would need to think about both how we manage that carefully, how we sought to secure additional capacity from potentially other providers, and also how we managed our comms in relation to this, because those are all absolutely critical components of how we're going to secure that this service is launched successfully as the numbers of patients who access it grow, which is really important for us given the social distancing we need to maintain in emergency departments and urgent treatment centres this winter. But I did want to just be transparent with the board. I made that point to the regional team because it is an ongoing area of concern that we're collectively managing. So I think Matthew's done a brilliant job of summarising where we're at, but I just thought that was really important to say.
Thanks, Jonathan. That's helpful. So questions, comments? Nicola, do you want to go first? You're muted. So I think you came off mute and then gone back on mute. That's it.
Oh, there I am. Is that better? Yeah. Okay. So first of all, I just want to say thank you to urgent care colleagues across the system, both folks on this call who've made this all happen really quickly, and those out there who are fine tuning it on a minute by minute basis at the moment. It's really been done very quickly, and thank you for that. I suppose I wanted to say that I think the messaging around this is really, really important and quite subtle, or there may be unintended consequences. And I've spoken about this in the urgent care group as well. NHS 111 first is a really powerful kind of thing to say, but if we end up going through 111 for everything, then that system will be overloaded with stuff that shouldn't be there, and the patient pathway is of paramount importance. You want to get to the right place as quickly as possible, and if we direct everything through 111 first, then actually that won't achieve good patient pathways in many cases. So NHS 111 first, rather than pitching up at an urgent treatment centre or in some cases A&E, is really important. But lots of people probably should go to their pharmacist first, or definitely to their GP first. And we don't want people circling around the system. So I know we're trying really, really hard to get this right, but I kind of wanted to say it again, really, because I think it's so important.
Thank you, Nicola. That's really pertinent. Liz, let me bring you in.
Sorry, I was just making a couple of notes on the previous point. In relation to patients' views of the system, in Kingston and Richmond, we're hoping, there's been some discussion in the comms group, to get feedback from users, and I think that would be very useful. But on a broader scale, I was just wondering what national evaluation there will be on the scheme, and I guess I'm coming at this as a former research manager at the Department of Health. You know, something on this scale certainly in the usual world would have a national evaluation by outside researchers, and there's going to be such an enormous amount of very rich data, and I'm just hoping that is going to be captured.
Thank you, Liz. So Matthew, do you want to say anything on that? Oh, Agnello, you've got your hand. Are you coming in to answer that one?
Yeah, I can do. So that data collation is already started. So in terms of the regions, London is already collating that information. We're getting regional information relating to that. There is a national programme and a national director at Department of NHS England, and they've appointed a national clinical lead as well. So that's actually coming together. Given the timeframes NHS England has set for coverage across the country, so that's in hand.
Thank you. And then Matthew, just back to you.
Thanks, Andrew. So, and there might be other comments I appreciate, but just on the point that Liz was making, I mean, I think she makes a very strong and important point. There is an opportunity to review this. It is a pilot at this stage. That's what it's been set up for. Not everybody's yet doing it. And I think as more experience and understanding is generated, it's beholden on us, whether it's in South West London or across London, to reflect on how this is working, because there are, certainly the conversations I've been having with clinicians locally, that there are some benefits to it. Certainly we've had some very good experiences fed back from patients, one who indeed I spoke to because I happened to know them and they'd been through the system, and they said actually it worked really well from their perspective, but it needs to not be an anecdotal, oh well, we've heard some good things about it. It needs to be a proper reflection on what's worked and what's not worked, because it's quite a significant amount of capacity that is being set aside for this, and we've got to make sure it's being used effectively. So I think you make a valid point. Jonathan and I are on a London-wide call every week about this work and other elements of urgent care transformation, and I suggest, Jonathan, that we make sure that we reflect back Liz's point at that next session, so that we can just make that point and hopefully ensure that exactly that sort of approach to reviewing this is undertaken. I'd also say Nicola makes an extremely important point that not everybody, and I was trying to be clear about it, apologies if I wasn't, this is an additional piece as opposed to an alternative and the only route through urgent and emergency care, and speaking directly with your GP, going to a pharmacist in all the normal ways remain there. This is intended to test whether or not you can make some elements of urgent care more bookable than historically has been the case. And I think there is merit in the concept, but not as the only way of doing it, and that's important from a patient's perspective. It's also, as Nicola rightly says, really important in terms of how the system works, because we could have a whole set of unintended consequences here and bigger problems created, which is not the intent, and interestingly is not what's happening in the pilots, but the risk is always there, and I think it's important to be supporting what Nicola and Agnello and others have said. So hopefully that's helpful, Andrew, by way of addition.
Thanks, Matthew. So I'm going to need to try and move us on. Let me hear your final point, Liz, and then I'll turn to Charlotte to wrap up. I imagine, Charlotte, you can probably quite helpfully cover the link to patient feedback and the role of Healthwatch in this as well. So, thanks. Liz?
Yes, I think that was great to hear. I think I would also, though, draw a distinction between, if you like, a pragmatic gathering of data by the organisations and by NHS England, and draw a distinction between that and if you like, a full-blown piece of research as well. So and I mean, we've got 45 years worth of research data on people's consulting behaviours that can be drawn on. So I'm hoping that the NHS England will also commission the NIHR or somebody like that to also be doing that fuller write-up of this, because I think it will raise such important points about how people think and about risk, and how people make decisions about who to consult when they're experiencing a health problem. So I'm very much hoping that data won't be lost, written up in that fuller way as well.
Thanks, Liz. And then final comments from you, Charlotte.
Yeah, just to kind of build on Nicola and Matthew's point, in that, we are trying to nuance the London campaign messages by having conversations with our community leaders and community influencers. So we are, saying to people, your A&E is still open if you're from a vulnerable group, so that people still know they can come to A&E and walk in, but also having those conversations around your GP and your pharmacy. So even though the communications kind of broadly, nationally and on a London level and they need to be quite simple, we are having those nuanced conversations with our community networks, kind of really explain the detail behind it.
Thank you, Charlotte. So I'm sure that won't be the last time we hear about the 111 pilot. It's going to be ongoing. We'll need to just keep track of that, particularly as we start to get more data through. I'm going to move us on now, though, to item 10 on the agenda, which is the board assurance framework. So Ben, you're going to talk through this, is that right?
Yes, Andrew, that's correct. Thank you. So I'll, given everybody's love of risk, I'll keep my introduction to this as concise as possible, but just to set some background and context for everyone. This is the first time that you've seen the board assurance framework. This is a culmination of work that we've been undertaking for the past few months to create a new single and up-to-date risk register and BAF for the whole of the new CCG. So in creating the new risk register and the BAF, we started by reviewing all of the risk registers from the 6 previous CCGs. We consolidated risks and themes that were common across all of those 6 into single risks for South West London. We also removed those risks that were either no longer relevant or had been resolved, and also reviewed the level at which risks sat and that they were sitting at the right level, so i.e. at borough level or at the South West London level. We then ran a number of risk workshops and conversations across all the teams in the organisations to ensure that we captured the right risks, that we were articulating them in the right way, and we'd also captured any new and emerging risks that were coming through. So overall, the risk register and the BAF have now been reviewed several times by SMT, and as alluded to in some of the previous items, they've also been, the risk register as a whole has been reviewed by the audit committee. It also regularly goes to the quality and performance and oversight committee for the specific quality and performance risks. And going forward now, each of the governing bodies committees will receive the risk specifically relevant to their committees and be asked to review them on a regular basis. The audit committee will also be reviewing the overall risk register on a regular basis, as will the SMT, who will be reviewing it on a monthly basis. So it's worth just remembering that this is the first version of the BAF that we've created and we've brought here, and that it is obviously very much a living and breathing document, and this will evolve and adapt over time. So we might not have it all articulated in exactly the right way at the moment, but that will grow and move as we go forward. So I wasn't proposing to go through the individual risks in detail at this point, as we don't really have time to do that. But I'm very happy to take comments offline from members. If you've got specific comments about the drafting, the scoring, the mitigating actions around that, please either drop me an email or do give me a call and we can discuss. So I think essentially what I'm asking the governing body for is to note the BAF and to really ask you if you think this is broadly in the right place, that we've captured the right risks and themes in the BAF, and whether you think there is anything that is missing that should be on there.
Thank you, Ben. So let's ask that question then to the governing body. What are people's views on the risk register as set out on the BAF? So let's come to you, Paul, as chair of audit committee, and then Susan, on to you.
Yeah, thank you, Chair. Ben, obviously we discussed this in some detail last month at audit committee and recognise the great work that's been done, and obviously it's still, I guess, some work in progress, but certainly heading in the right direction. I just wanted to ask the question. I think we raised it at audit committee, but how are we linking up with the boroughs to make sure that, you know, they're keeping a risk register and we are capturing perhaps the key risks on a borough by borough basis? Because there's a danger, as I think we identified, we can be very high level and miss specific issues that pertain perhaps to just one borough and no one else. Thank you.
So that's a really helpful question, Paul. Let's hear from Susan, and then Ben, I'll get you to respond to both.
I was just going to say I found the framework really helpful, and as the chair of the Primary Care Commissioning Committee, keen to work with Mark, who's the SRO for primary care now, in understanding the risks around primary care, making sure they feed in, which sort of builds on Paul's comment, really, that we've got a connected strategy that builds up from boroughs and also programmes into a governing body. And also, perhaps we need to think in the future about its relationship with the wider ICS and where the risks overlap between us and the system as a whole.
Yeah, thanks. So, Ben.
So absolutely agree with all of those comments. And what I've been trying to do is really build this in layers. So now that we've got the cross South West London risk register established, the next thing I've asked the team to do is concentrate and work with all the boroughs on identifying their risks, and that we have a clear escalation process through that, which is set out in the risk management framework. We need to do a bit of tweaking to that before I bring it to various places to sign off, but that's very close. We have had borough risks, and some of the boroughs do already have their own risk registers, but we need to formalise that in a way that we can escalate them up through the system, as both Paul and Susan has established. Once I've got that borough piece done with the South West London wide one, then I was going to have a conversation with Karen and her team about how we make sure that we're capturing the right risks on the right registers, and that we're making sure that we've got the right interactions between both the CCG level risk register and the system level risk register.
Thanks, Ben. That's really helpful. I know it's a complex piece of work, but it sounds like it's coming together, which is good. And Paul, you're going to keep monitoring that in audit committee as well.
Absolutely, yes. Yep.
Okay, great. Thank you. Well, look, that was for information. Really helpful to see. Thank you, Ben, for that. I'm going to move us on straight on to item 11, which is the mental health complex care business case, which was looked at in Finance Committee with a recommendation to approve, and because of the timing of this, sought Chair's action outside of the context of the meeting. It would normally be a decision for the full governing body, but I had to take Chair's action on this, and what we're now seeking is ratification of that decision. So, Tonya, over to you just to give us an overview of what the case was and where we've got to.
Thank you, Andrew. I'm just taking breath at the moment, so apologies if I'm a bit slow. So the complex care business case has been a couple of years in gestation, really. It's been worked up with the South London Partnership. And for those of you who are not familiar with the South London Partnership, they're a mental health provider collaborative with the three mental health trusts in South London. It's Oxley's, Slam, and South West London St George's. And one of the priorities nationally for the provider collaboratives was to take on the responsibility for the commissioning and potential provision of services for complex mental health patients, and we're talking here adults in this instance. So the proposal, what's happened recently, these are about people who are in long-standing, probably mostly sometimes inappropriate placements. So the CQC and due diligence reviews have shown that people within these placements have poor outcomes. They're placed too far from home, they're in over-restrictive settings, and they remain in placements longer than necessary. And it's felt that the real benefit for provider collaborative, they can work very much with their clinical assessments teams to work with individuals to move them on to more appropriate accommodation. And to date, the team has reviewed around about 50% of the supported, 50% of the people that are currently in these placements, and 87 people have been able to they've been able to step down, 87 people, with another 82 to be stepped down in the next 3 to 6 months. And some of these individuals have been in placements for 5 years or plus. They really have been in placements for far too long. There's also a very uncoordinated market with over 400 providers. So if you remember previously, it's CCG's responsibility mainly to place these people with very small numbers per CCG historically, and actually we all use the same providers, and actually that hasn't been the most effective way. By doing this, we also have the opportunity to transform rehabilitation services through reinvestment savings and actually look at the pathway, and also develop new services. So we've seen an increase over the last couple of years around people with emotional unstable personality disorder. Again, you wouldn't develop services on a single CCG footprint, even if probably an ICS footprint would be a challenge because the numbers are quite small. But actually we can do a solution at scale by working with the South London Partnership. So the proposal is that we delegate, firstly, delegate the health element of the 100% fully funded health placements to SLP to manage on our behalf, and then we will work with the local authorities to delegate our joint part of the health part of the joint placement. So it wouldn't be delegating the local authority funding to SLP, but we would be delegating the health funding element of those joint placements as well. I'm sorry, I don't have the paper in front of me, but I believe it's about £33 million that we're looking at, and that's around 600 patients, I think. Sorry, I haven't got the numbers in front of me, but you have the paper. So that's and the reason we went for Chair's actions, we had a deadline around the 1st of November to get the letters out to provide to say the change in contracting arrangements, so that the contracting for these places and the payment of invoices will be done by SLP rather than with the CCG. Just a quick run through there, that it's a very big business case. You can see the detail there, but I'm happy to take any questions.
Thank you, Tonya. David, you obviously had a chance to discuss this properly at Finance Committee. So where did you get to in your discussions there? Because the recommendation came from Finance Committee to approve this. So I guess it would just be helpful to get that insight.
Yeah, thank you, Andrew. And we did have this was presented to Finance Committee. We had the opportunity to go through it in some detail, ask questions and to scrutinise it. I guess there's two areas for me. One is around, the overall, what's the rationale for doing this, and secondly, the financial implications. So firstly, on the rationale, I think we were agreed that this seemed to be the right thing to do. We are talking about a significant amount of money for this group of patients, so we were very happy that in moving the financial responsibility to the partnership of providers, that was a better opportunity to improve services and also reduce costs. And also there is issues around that manages our financial risk as a CCG better. And then secondly, the paper does set out in some details the way the money has to move around the system. So there will be additional programme costs to make sure that we can follow through on this, but those can be offset as savings. So our overall view was
this did seem to be the right thing to do, to work in this way, and it was on that basis, therefore, that we recommended that the board should fully support this.
Thank you, David. That's really helpful. Are there any questions or comments on the case? No. So I'm assuming then that people are comfortable with that and with the recommendation from Finance Committee. I would like you to ratify the decision. So I've had to take the decision outside the meeting because of the timing, but I would like the board to formally ratify that. So can I confirm that is the case, that we're happy to approve that? David, you've got your hand up.
Sorry, Andrew. Yes, my answer to that is yes from me. But can I just say what we did say, as this is a significant change, one of the things the Finance Committee will do is to come back to it. So it'll be on our agenda for review in the future, because otherwise there's a danger when we're making big decisions like this that we lose sight of, well, so have we really delivered the impact? So sorry, just to say that we will come back to this at some point, maybe 6 months time, just to see where we're at with it. So sorry, I forgot to mention that.
Thanks, that's helpful. Okay, so from the nods, I'm taking that as ratified. So thank you, everyone. That's the decision. So let's go straight on then to the section on public questions. Now, we've had one question in advance by email, no questions in the chat during the meeting. So I will take that question now, and then I know we have an item of other business that Sarah is going to tell us about. So the question that we've had in advance was from Tony Burton, who's Secretary of Mitcham Cricket Green Community and Heritage. Well, there's two questions, and they're as follows. Please, will you confirm whether it remains your intention to open the repurposed Wilson Hospital in Mitcham by the end of 2022, or otherwise confirm a revised date? Please, will you confirm when a planning application for the repurposed Wilson Hospital in Mitcham is scheduled to be submitted, and what prior engagement with local organisations and the community is planned before this occurs? So this relates to the Wilson Hospital site in Mitcham, which Merton CCG has been working on plans for many years to try and get this delivered, and obviously the date previously had been set at the end of 2022, so quite reasonably the society based at Cricket Green is asking for an update on that. So I'll refer this question to Merton Borough team. So Vasa and Mark, between you, I think you're going to take this one.
Thank you, Andrew. I'll take this one, Andrew. I think it's a very important question, and it's the first time this is being raised in a governing body for South London CCG. But as you said yourself, in Merton, this has been an important issue for us for a while. And if you may take a little bit of time to give you a comprehensive answer on this, because I think this is a very important question for Merton. The health and well-being hub plan for Mitcham and surrounding communities remains a key priority for South London CCG. It also remains key for the place of Merton. We have spent, as you said, a number of years designing the model of care and agreeing the services we want to deliver to get the best and to meet the needs of the population who live in the local area. The facility we want to provide and will provide adult mental health services in modern, accessible surroundings, a children's centre, a mental health service for children and young people, a community-based well-being service on the site. We are improved signposting. We will support people to manage their health and well-being outside of a clinical setting in the community for the community. The engagement which has gone on for years up to date, working with a number of stakeholders across the health and care system, has informed these requirements along with information from public health about ensuring future service provision meets the needs of our population. The hub will provide promote the use of green and health spaces to improve well-being and combat loneliness and social isolation via community and neighborhood gardening schemes and many other things which will build as we go along. We are currently exploring options for delivery, and we'll be in a position to share the outcomes in spring 2021. The facility, unfortunately, will not be ready to open as previously estimated, as you alluded to, in 2022, but we will share the revised timelines and a new estimated date for the earliest opportunity to answer that question more specifically. There are no plans at this point in time to submit a planning application, but we will follow due process in terms of informing and sharing and engaging and on consulting with all our relevant stakeholders as appropriate, leading up to any planning application as we know more. In the interim, additional investments have been made in refurbishing the current Wilson Hospital site and the grounds for use by community organizations. This is part of our joint commitment to promote well-being and social prescribing services in the area around Mitcham. We expect to be able to provide more information about this in the coming weeks. And finally, please be rest assured that this remains a key priority for South Western CCG and also for the Borough of Merton, and we will continue to do all what we can to make this a reality.
Thanks, Vasa. And I know there'll probably be further conversations outside of the meeting with local groups, including Cricket Green. Anything further that you wanted to add, Mark, or not? No. Okay. Thank you, Vasa. That was a comprehensive answer. Obviously, we can't give the degree of certainty that people would like, but I know it is a top priority, and I know there's a lot of work going on just to try and find a way forward for that. So, look, that brings me on to any other business. So I'm going to hand over to you, Sarah, because I think there's something you wanted to update us on.
Yes, just so that the governing body is aware, and obviously we're in a public meeting, there has been a media briefing whilst we have been meeting as a governing body by NHS England and I, with the Chief Executive of the NHS, Simon Stevens, and the Medical Director, Stephen Powis. And they have announced that the NHS will be moving into a level 4 incident again from midnight tonight. That obviously will not impact on what we are doing with our public, and that it will continue. What it may well impact on is how we use our resources in the NHS. So we'll be again focused on the next wave. We know that going into the lockdown, we are seeing increases in our hospitals and across our systems, and we need to focus our resources in the right way to respond to that second wave of COVID. So we will let you know as soon as we have the details about what that means for us, but I am expecting to switch our resource again back into response to the pandemic. So level 4 incident from this evening, or from midnight tonight.
Thank you, Sarah. I mean, when you say switch our resource into the pandemic, you mean obviously focus on dealing with wave 2, but we are planning on continuing, as we talked about before, the planned care activity, the operations that we previously planned.
We will continue all of the operations that are focused on our response, which means all of our planned care, all of our business as usual that we're trying to continue through the pandemic. What I'm talking about when I say the resources, I mean mainly our administrative staff or our support staff, much more focused on the response than, you know, perhaps some of the governance that we've currently got in place. So we will work through the recovery board, which is our main focus from the COVID response, and we will continue throughout the level 4 incident for however long that goes on.
Thank you. So any quick questions for Sarah on that? Obviously, we've just had the announcement, so information emerging at the moment, but thank you for letting us know that, Sarah. Okay, I've not been notified of any other business, so that brings us to an end of the meeting. Thank you everyone for your time. It was a long meeting, but people managed to maintain focus and energy, and there were some really important discussions throughout the whole meeting. So thank you everyone for your contribution. I thought it was really helpful. So that brings us to a close, and I'll formally end the meeting.